donations which we actually like it to be in the way it should be. So, sorry. So I'm just going to start off with my first slide. It is not what you actually have, but it's what you give back to the world which makes a difference. And I'm just going to start off with a simple case. This is a hypothetical case. This is not a real case, but a young motorcycle rider had a head on collision, a severe head injury, GCS of 3 on presentation, no pupillary reflex, no eye lift, no cough, gag, nothing. And family and colleagues asked whether he's brain dead. Now, this kind of a scenario does not happen in reality, unfortunately. The first half happens. You do have such patients who come in with accident, but rarely the family would come and talk about brain death or go ahead and talk about organ donation. There are, in fact, some patients and their families who are very well aware of the organ donation as a concept, and they would bring it up on their own. But why am I saying this? Because it is our own colleagues, our own doctors who are very hesitant to use this terminology as brain death. And sometimes when they use it, at times they use it very loosely. Brain injury is often, essentially mentioned as brain death. And brain death, we try to beat around the bush when there is clear-cut brain death. We never sort of talk about it head on that this is brain death. And it's quite okay because not everybody is sort of well versed with the death and dying talk. But we all need to be at least using the terminologies clearly so that the person who is an expert in your hospital who can communicate well will actually go across and talk about it in a more rational way to the family. This happened in Lilavati Hospital. I've taken this from Times of India website. This was 10 years ago exactly. We have moved a large quantum change from this point, 2012 to 2022. Most of our policemen are actually now well versed with organ donation and brain death. That's because in the last 10 years, the ZTCCs of Maharashtra have taken a large amount of teaching for the police and police people, and IMA and all those people who have been involved in these teaching sessions have actually made the police force sensitized about the organ donation and brain death. Why? Because majority of our patients actually do come from MLC cases, and police is invariably involved in them. So they need to be aware of what is happening. And I have myself gone to at least 4 or 5 police stations to take up lectures for police people so that they're at least aware of it. Unfortunately, this kind of education does not happen in our general doctors, and that's why they are probably a little bit ignorant, where they should be even more aware and on top of things in terms of how do we actually talk about brain death, what is it, the concepts and everything. So let's move on. The incidence of organ failure is huge. I'm not going to go into the incidence. The topic is actually to go and look at the organ donation. This is just an international comparison. This is way back again. We are around 0.2 to 0.5 per million population. States like Maharashtra, Tamil Nadu, Gujarat, Maharashtra, Tamil Nadu, Gujarat, Kerala are around 3. But as a country, we are very behind. And look at some of the countries, Spain, Australia, they are well above 20, 30 donations per million. And I think we are just not actually identifying these donors very early. So the concept starts from doctors understanding when did the death occur. When does a person say that the person has died? I will give you a live example. Archana madam, I'm going to take some time to just explain things, so just bear with me.
Sir, please, absolutely free.
The declaration of death in Sydney happened in 1968. So we are talking about almost 52 years ago, 53 years ago. Now, it is important for us to understand this last line. The clinical interest lies not in the state of preservation of an isolated cells, but in the faith of a person. Once the point of death of different cells and organ is not as important as the certainty that the process has become irreversible. So you have to be certain that this process is irreversible. I'm going to give you an anecdotal example of that. All of us have been in a cardiac arrest situation in our hospital settings one time or the other. Okay, we see that the patient is arrested, the nurses, the doctors, they start doing CPR, and we keep on trying to revive the patient. Okay, at around 15, 20, 30 minutes, the process becomes certain that it is irreversible. In this 20-30 minutes, some doctor who is usually the leader in the whole group, whoever is present, keeps on communicating with the family that the patient is not good. We are trying our best. Heart has stopped. It looks extremely unlikely that he would survive. So all those things about communicating or breaking a bad news are done by them. The family, if you step into the family shoes, the family is still waiting, clenching their fist and hoping that against the odds something would happen and the heart would come back. While all of us within the heart and heart know as doctors and nurses that this is an irreversible process, but the family is still sort of hopeful. What happens is that at one point where when you become certain that this process has become irreversible, you stop the CPR and you go and tell the family members that I'm sorry, we tried everything, but we couldn't save your loved one. That is the point when the family actually accepts it. There may be reactions of anger, grief, whatever it is, but that's when they have actually heard that now this is not possible. The person is no more. Till that time, they had some hope. Okay. So for doctors and for families, process of irreversibility is different concepts. You may have had the irreversibility concept 20 minutes before when the CPR started, but for the family, the concept only became clear when you actually mentioned the word that the patient is no more. Why am I emphasizing this? That as a neurologist, as an intensivist, as a neurosurgeon, the process of irreversibility may have been clearly understood by you. But for the family, you have to go and tell that the patient is dead by brainstem death criteria. Only when you say those words and then explain them what it means, and I'm going to give you some example as we go across that how do you actually talk to them, is when they will understand. So the process of irreversibility has to be good. What happens very often is the doctor will come and say, ब्रेन स्टेम कुछ ब्रेन साइंस कुछ दिख नहीं रहे, 24 घंटे के बाद देखते हैं, चलो देखते हैं, चालू तो है सब कुछ, क्या करना है देखते हैं. We all sort of beat around the bush. We never go and address the problem and tell them that this is an irreversible thing. This happens in most of the cases. Yeah, some institute, for example, I can vouch on my institute that if I have a brain dead patient, none of our doctors would actually go and say this. They would say that this was very difficult. We need to check whether the brain is functioning or not, and we would probably have to think whether this patient is brain dead or not. That's how they would address the patient family. So it's just a way of sort of bringing across your conversation. Before we get on to the nitty-gritties, let's understand the concept. So this is our normal brain anatomy. In India, we look at the brain stem death. We don't go for a whole brain death concept. We look at the brain stem death concept. Our organ donation, the cadaveric organ donation is based on brain stem death, not on a whole brain concept. So we test the brain stem. That's what we do. So that's the first thing we need to understand. This is normal brain anatomy, cerebral cortex, brain stem, and the reticular activation system. I'm just going to go fast because we all know this. So brain cortex looks at cognition, voluntary movement, and sensation, whereas the brain stem, which includes midbrain, pons, and the medulla, actually looks at various functions, which are depicted by functions of the various cranial nerves. That's the way you actually test the brainstem. You test the brainstem by testing the cranial nerve function. And obviously the medulla is also the respiratory center. So you test the respiratory center by subjecting the patient to an apnea test. So these are the cranial nerves which we look when we study the midbrain, the pons, and the medulla. And the last one is the respiration. Okay. So before I come to the death, we need to understand what does our Indian law say, because this is what protects us. This is what is going to be our basis on which we are going to declare a patient dead. So the Transplantation of Human Organ Act of 1994, which is a central act of Government of India, describes a deceased person, means a person in whom permanent disappearance of all evidence of life occurs, one, by reason of brain stem death, or in a cardiopulmonary sense at any time after a live birth has taken place. Third statement in that act is brainstem death means the stage at which all functions of brainstem have permanently and irreversibly ceased. This is the most important thing which we need to understand. So our act, our Government of India Act, allows us to declare patients dead by two means. One is the cardiopulmonary sense, which all of us understand, And there is absolutely no doubt about that, which common people also understand, and they don't have any doubt about that. However, the brainstem death criteria requires first our understanding so that we can make the common person understand what brainstem death is. If we are not certain of what to talk about, they will of course not understand, because they are lay people. So we need to understand what it is. So the first thing to understand in brainstem death is that, do I have a patient who has a clinical diagnosis and a proof of that clinical diagnosis which is consistent with the progression to brain death? I think that is what one needs to, first step is what one needs to understand. When I am called to see a patient that this patient would be potentially brain dead, I always ask them, what is the diagnosis? And please show me the CT or the MRI, because those are the two things which tell me that yes, this diagnosis is consistent with brainstem death. So this is just a normal brain. So you may have a patient who may have severe cerebral hypoxia or anoxia due to whatever reason, post cardiac arrest, due to hanging, whatever it could be. But that could be one of the reasons. Then obviously you have patients who have large intracranial bleeds, cerebral hemorrhages. Then you may have a patient who may have a massive subarachnoid hemorrhage. Then you may have a patient who may have traumatic brain injury. Then of course you have patients who may have infective etiologies like meningitis. And of course, these are just some of the cases where I have sort of depicted. But one needs to first look at the case and see whether the diagnosis can be consistent with brainstem death or not. There are some cases which would mimic brain death, and I'm going to come to that as well. But the common one here, which I would like to exclude even at this stage, is that has the patient taken an overdose of organophosphate poisoning or overdose of benzodiazepine, where he's so deeply comatose that the reflexes are not elicited right now, or a crate poisoning for a crate bite, for example, where they have a complete neuromuscular paralysis, or was it a progressive paralysis which happened like a GBS? I've seen GBS patients who are completely, areflexic, and when I'm talking about areflexia, I'm talking about cranial nerve reflexes here, completely areflexic, and they would actually mimic brain dead. So you need to do a CT scan. If the CT is normal, walk away. Tell them this is not brain death. You please consult a neurologist, readdress your diagnosis. This has got to be something else. If the brain scan is normal or the brain scan is not giving you a clue that this can be brainstem death, do not proceed further. That's the first thing which one needs to understand. But if the brain scan is like this, the one which we are seeing here, then you obviously don't need to worry. You know that the diagnosis is quite consistent with brainstem. You need to go and check the patient. Now, how does the brain death occur? This is a very simple slide prepared by me. You have a neuronal injury. This neuronal injury, we all know any type of an injury in the brain gives rise to a neuronal swelling. And then you have an increase in the intracranial pressure. We all know the Monro-Kelly doctrine. Monro-Kelly doctrine says that the skull is a fixed volume compartment. It has got the brain matter. It has got the blood which comes into the brain circulation, and it has got its CSF. So if one of the thing was going to expand, and in this case, the neuronal swelling means the brain parenchyma is expanding, it will be at the expense of the other two. And the other two is the CSF and the blood. So because it's a fixed compartment model, as the intracranial pressure increases, your blood flow into the cranium starts to drop down. At one point, it becomes a vicious cycle. And as the vicious cycle keeps on going up, there will be a point where the intracranial pressure will become more than your mean arterial pressure. Mean arterial pressure is the one which actually pumps the blood into the cranium. Once that intracranial pressure goes beyond the mean arterial pressure, it becomes incompatible with life. That is what in common language we say that now the patient has coned, and the coning has happened, and the patient is now essentially going to an irreversible process. Not every time we measure the intracranial pressure. In fact, rather, most of the times we don't have any idea of the intracranial pressure. We go by clinical judgment. When the coning happens, there is sudden tachycardia, hypertension, followed by a severe hypotension, and sometimes even heart rate changes, arrhythmias can come across. So this is the essential mechanism. One needs to understand the mechanism. If you can intervene, you have to intervene at a very early stage to see if you can save the patient's life. Nowadays, if you see, we don't get a lot of patients, at least in bigger hospitals, where patients are becoming brain dead after a traumatic brain injury, because the neurosurgeons are very, very capable nowadays, and they actually go and do a decompressive craniotomy. Once the decompressive craniotomy is done, the intracranial pressure can never rise above the mean arterial pressure. So you always will have a patient who will have severely brain injury, but they will not progress to become brain dead. Some reflexes may still be present. Okay, so that's the mechanism of cerebral death. What are the criteria by which we establish, clinical criteria by which we document death? So first and foremost, we need to understand that there are 4 ways in which you can diagnose brain death. The first 3 are the only ones which are allowed by the Indian law. The 4th one, or the ancillary test, are not allowed by Indian law to be actually taken up as a brain death certification. They can be taken up as an extra step to convince ourselves as doctors, if at all you wish to do it, but it has got no legal standing. You cannot say that I have demonstrated cessation of intracranial blood flow and hence I am declaring patient brain dead. While it should be included, but currently that is the law. The law says the first 3 are the ones which we look at. So what do we look at? We look at irreversible coma, we look at irreversible loss of brainstem reflexes, and we look at cessation of respiratory center function. We do not go across and look at the demonstration of cessation of blood flow, because that's not something which is a part of it. Sometimes even I have done a CT angiogram to see the blood flow, but that is for me to be convinced about it. Has got nothing to do with the patient's legality of declaring brain dead. So as we come now closer, you've identified the CT scan and understood that there is a cause. You now know that this is the way in which you are going to prove which is an irreversible coma, absence of brainstem reflexes, and you are going to look at cessation of respiration. The first step now is that, is the underlying cause clear for the patient to be brain dead? We've already looked at the different scans. So look for potential causes of brainstem dysfunction. If there is no obvious cause, be cautious about diagnosing brain death. Make sure there are no confounders that mimic brain history. Always take a history and make sure that you are convinced that this can be brainstem death. Okay. Actively look for confounders before you proceed on. So what are the confounders? Severe hypothermia, patients who may have temperature below core temperature. Again, each word is very important. Very often in India, axillary temperature is taken, and trust me, axillary temperature will keep on coming normal because we are very good at surface warming. We keep the patients wrapped up in the blanket. If you keep the temperature probe in the axilla, it will show a temperature of 36, 37 degrees centigrade, and you will be, considering that this patient is absolutely warm. You have to insert a nasopharyngeal, esophageal, or a rectal probe or a bladder catheter probe to actually look at the core temperature. Now, fortunately for us, hypothermia is not a big problem because our country is such a warm country. At least in this side of the continent, in Maharashtra, we never have sub-zero temperatures. So patients coming from community to us with that much of hypothermia is not common. However, a brain dead patient becoming hypothermic to 32 degrees is very common, because hypothermia is something which is identified by the brainstem, the hypothalamus. And because the patient is brain dead, the temperature control mechanism of the body is lost. So patient's body actually cools down quite quickly to the ambient temperature. And you will often see that everything was suddenly normal and now the patient has become bradycardic. You will start seeing Osborn J waves, and you will maybe see a sudden drop in the cardiorespiratory system and a cardiac arrest for this patient. And when you put a probe into the esophagus or the rectum, you will see that the temperature is well below 32 degrees, which is not compatible with cardiorespiratory system functioning. If you have a patient who is severely hypotensive, systolic pressure of less than 100, always wait. If you think that the patient had a presence of alcohol, any sort of poisoning, including snake bites, recent use of sedative or neuromuscular blockade, take 2 steps back. And some medical conditions like severe electrolyte abnormalities, especially sodium abnormalities, which is hyponatremia, not hypernatremia, hypoglycemia, and severe metabolic acidosis with pH less than 7.2, you should always be worried that these are not the preconditions which are fulfilled. So what do? You correct them. You bring the patient back to physiological normal ranges as close as you can. And then if still the patient has got no reflexes, you think, yes, now I am ready to test the patient for brainstem death. So these are the preconditions which have to be fulfilled. You have to have a warm patient. You have to have a patient who has got systolic blood pressure, which is at least 100 millimeters of mercury. You have to wait for alcohol and poisons and toxins and sedations to be out of the body. And that sedation should basically be 5 half-lives of a sedation you need to wait. So if you have a half-life of 2 hours, you at least need to stop the sedation for 10 hours before you can say that the sedation is out of the system. This is provided your renal and your liver functions are normal. If you have abnormal renal function or liver function, you have to take that much into consideration and you may have to wait longer for that. Medical conditions, sodium corrections are required. Again, the correction should be done in the way it should be normally done. Hyponatremia should not be corrected more than 10 millimoles per day in a 24 hours time. Whereas hypernatremia can be corrected rapidly if all other conditions are normal, because hypernatremia is usually a complication of brainstem death rather than actually a complication of hindrance to the brainstem death. So these are some of the things which we need to remember. So some of the practical tips: insist on core temperature. Always look for history of drug overdose. I have now made it almost compulsory in the last 10 years that we use a peripheral nerve stimulator. Peripheral nerve stimulator is available in the ICU. We use a peripheral nerve stimulator and look for a train of 4 response, a TOF response. And if there are 4 twitches, we are very clear that the patient has got no neuromuscular blockade. So the majority of these patients have got some form of sedation or neuromuscular blockade given to them. So we should be clear from our side. Though it's not a mandatory requirement, this is just a practical tip which I am giving you so that you take it out of your calculation completely. Always I do a ABG before I go and examine the patient so that I have the most recent values of sodium and potassium. Sodium, as I've already mentioned, is important. Potassium, sometimes hypokalemic periodic paralysis can mimic like a brain death where patient does not move at all, where the sodium, if it is below 1, yes, you may argue and say that you will have a threat to life. But then, yeah, we do see once in a while, we should be clear that we will see cases of all types. Hence, most recent value of sodium and potassium should be available. And I always insist on ABG, as I have already mentioned to you. Then I identify the patient by a complete neurological examination. What does that mean? Before going to this step, I'm going to tell you what I talk to the family. Look, when I'm reaching to this point, I have spent several hours with the family talking and explaining to them about the patient's condition, about the poor prognosis. And then comes a point when I tell them that, look, we have looked at your dad, mom, or relative, whoever is there in the ICU. And unfortunately, we are not seeing any brain activity. And we would like to do a formal testing to understand whether brain is functioning or not. Obviously, the relatives are lay people. They will ask, Doctor Saab, iska kya matlab hai? What do you mean by that brain is not functioning? So I have my own way of communicating with them, which I'm going to share with you. I tell them that when I'm asking or when I'm seeing that the patient is having any brain function or not, I check those reflexes with which we are born. When a baby is born out of the mom's womb, at 1 minute of his life, whatever reflexes are present in a normal, healthy baby, are those reflexes present or not? So the baby at 1 minute is able to breathe on its own. He does not require anything. The baby has got a pupillary reflex and a corneal reflex present. The baby has got a cough and a gag reflex present. When you give a painful stimulus to the baby can elicit painful response and can throw away your arm or start crying even at 1 minute of his life. These are the basic reflexes which we don't have to learn. We are born with these reflexes by the God's nature, by the great Almighty. Everything else, walking, talking, learning, smiling, writing, everything else we learn. We learn as the milestones progress, but at 1 minute of our life, whatever we are there is what we test as the brainstem reflexes. These are the reflexes which are natural reflexes. They are basic reflexes. And if they are absent, that means the life is not there. Brain is not functioning. I further go on and talk to them about the question. Obviously, in this discussion, I always have a question which comes to me by saying, "But sir, heart to chal raha hai," which is right because the patient is on a ventilator. You have to address that question so that they can understand. So I tell them the same analogy again. I tell them when a mother is pregnant, even in the 5th or 6th week, you can see the heartbeat. So does that mean that we start celebrating our birthday when we were 5 weeks old in our mother's womb, or we celebrated when we were born? So obviously the answer comes that nahi, nahi, hum to celebrate karte jab when we were born. So what was the difference? Heart was there at 5th week of our gestation. Why are we celebrating our birthday on the day we are born? Because on the day we are born, we start breathing. That's the most important difference which happened. Heart was always there, but when we breathe on ourselves without any support, that's when we are born. And that's when the family understands very clearly that breathing is a reflex which only happens when you actually are out of the mother's body. And that is what denotes life. Heart just does not denote life. And then I go on to explain to them that because the breathing here is artificially supported by a ventilator, the heart is also functioning for some time. As soon as the ventilator was not there, the patient would not be breathing, and you would see that the heart is also not functioning. So that is when the family understands, and obviously I have mentioned this to you in 4 or 5 minutes. I obviously take a long time to go through this conversation and make each of them understand every point before we actually progress on. I also offer one of the family members to come and witness the test done by me at the bedside. This helps them to understand what is being told to them in the room when I was discussing with them. Each test, I go with them before I actually take them to the bedside, and I then demonstrate them each test. And that way, they have a full trust and confidence on us that whatever was discussed has been done. And when they see that the patient's ventilator is disconnected and the patient is not breathing for 7-8 minutes, they actually have acceptance of the brainstem death more easily than what we would do by just talking to them. So when they see it being done, the acceptance is very quick. So now the question comes, when should we do the testing and who does the testing? Testing can be done after 4 to 6 hours of no recordable brainstem sites by a bedside nurse or a doctor, provided all the preconditions are met. Testing is done by 2 doctors separately at an interval of 6 hours apart. The doctor can be a neurologist, intensivist, neurosurgeon, or a person who is qualified and certified to be on the hospital brain death panel. That brain death panel is certified by the appropriate authority. The hospital has to send the list to the appropriate authority. In Mumbai, the appropriate authority is the DHS. In every city, there would be an appropriate authority through whom you need to certify that these are our brainstem death panel doctors. 2 more doctors observe the process. One of them is the primary physician under whom the patient is admitted, and the other person is the hospital administrator who signs by basically saying that, yes, this is happening in my hospital and I am aware of it. This is what the law says. The Form 10 has all 4 of us signing. So now we go to the actual process of documenting death. So we document coma, we document absence of brainstem reflexes, and we document apnea. I'm going to take them quickly through you. So I start pre-oxygenating the patient with 100% oxygen, and I obtain an ABG, as I've already mentioned, which will give me pH, blood oxygen and carbon dioxide levels, electrolyte, and blood glucose. So I know that my physiology is normal, my biochemistry is normal, my oxygenation is normal, my monitor tells me that my hemodynamics are okay, my ventilator tells me that I'm on minimum oxygen, and I have got 100% or a good PaO2 saturation or a PaO2 on the ABG. That's when I proceed to start looking at it. So what do I do? First of all, I look at absence of motor response by a standardized deep painful reflex. Beware that local spinal reflexes can be there. Spontaneous movements can happen in patients who are brain dead because below the spine, below the neck, everything else is intact. Spinal reflexes should not be mistaken as brainstem reflexes to a painful stimulus. And that's why it's important that sternal rub should not be done. What you need to do is either you need to do a trapezius squeeze, or you need to press the medial canthus of the eye, upper eye, so that you actually press the ophthalmic branch of the trigeminal nerve here, or you press the spinal accessory nerve here. If you do a sternal rub, it may be a painful stimulus, but you are actually stimulating the spinal dermatomes. That's not what you have to test. You have to test in the places where afferent and efferent is by cranial nerve. Within the cranial nerve distribution, you should be able to give a painful stimulus. So only here, so obviously do it on both sides, or you do a spinal accessory nerve squeeze by giving a trapezius squeeze. Those who are anesthetists can do a jaw lift. Jaw lift is also a very painful stimulus, and that will be again in the trigeminal area now. Then you document loss of brainstem reflexes. I like to go rostral to caudal, pupillary reflex, oculocephalic movement, dorsal movement, cold caloric test, corneal test, cough reflex, gag reflex, all of them. So pupillary reflex, obviously shine the light in eyes. Corneal reflex, you look at. So again, examine on both sides, please. You look at the corneal reflex by a cotton wasp. You look at a gag reflex by actually inserting and touching the soft palate with a torch in the hand so that you can see whether the patient's palate is arching up or not. Don't just sort of blindly just insert and say that nothing is moving. Cough reflex is very easy because they are intubated. You can actually put a suction catheter in and you can aspirate out and see whether the patient is coughing or not. I always try and uncover the patient's belly so that the abdomen is visible for me. Whether the cough reflex may be weak, I should not miss out on the cough reflex. So not only do I see the belly, I also look at the monitor and all those things to see whether there is any stimulation of the cough which is happening or not. Okay. The cold caloric test, 20 cc of cold saline is injected in each eye, and one person keeps the eyes open for at least 1 minute after the injection to see whether there's any deviation of the eyes on the side of the injection or not. The cold saline should be kept ready. You should make sure that the ear does not have any wax or the eardrum is not perforated, because the caloric test means that you need to actually put cold temperature change on the eardrum. And for that to happen, your eardrum should be actually visible so that there is no wax, and it should be intact so that the reflex can be elicited. Once these things are done, we come up to an apnea test. So generally when you start up, around 7 to 10 minutes go by before you do all of these tests one by one, because you need to document it very, very clearly. Now, after I have documented coma by the absence of painful reflexes, I've documented absence of brainstem reflexes, I now come to the apnea test. So I've already pre-oxygenated the patient for around 10 to 15 minutes. I've done an ABG. I disconnect the patient from mechanical ventilator. I continue to oxygenate the patient through a catheter placed in the trachea and aim for a saturation of around 94 to 95. The catheter which goes is connected to a flow meter which gives a oxygen flow rate of around 4 liters per minute, and ABG is repeated in around 8 to 10 minutes. Why 8 to 10 minutes? The target is that your respiratory system has to be stimulated by your PaCO2. Your normal PaCO2 is around 40 millimeters of mercury. Okay, so you need to aim a PaCO2 of 60 millimeters or 20 millimeters from baseline. Now, very often this 20 millimeters from baseline is misinterpreted. Give me a minute to explain that. So as I said, when you start to do a brainstem death, bring all the physiological parameters to a normal range. That means that even your PaCO2 should be between 40 and 45 when you start. Sometimes there may be a CO2 retainer in whom, despite your best efforts, your PaCO2 may not come below 50. In those cases, you cannot say that I have gone to 60 and I am declaring the patient brain dead. In those cases, this 20 millimeters from the baseline has to be used. Whereas for every other patient, you need to go from 40 to 60 so that you increase it by above 60. And around 1 minute of apnea gives rise to a CO2 of around 3 millimeters of mercury for every minute of apnea. So if I have to go from 40 to 60, I will require at least 7 minutes of apnea. So 7 minutes of apnea is something which you rarely require. If this is a ballpark figure, some patients may reach very early, some patients may reach maybe even in 9-10th minute. It also depends on how much oxygen you are going through that catheter. So don't give too much of oxygen. I always make sure that the patient has an art line so that we don't have to fumble when we are collecting the ABG, because at that time you need to collect the ABG, get the reading done quickly so that you can disconnect you can connect back the ventilator if the CO2 has reached to 60. If the CO2 has reached to 60, then we always declare the patient that yes, the apnea test as well as all the documentation of coma as well as all the cranial nerves actually are consistent with brainstem death. And the first set of tests is completed. Once the first set of tests is completed, I go to the family. So as I said, usually the family, actually one of the members of the family, I allow them to watch. Sometimes even two, I allow them to watch. I go to the family and tell them that the first tests are consistent with brain death. And I allow them to sort of have the news sunk into them that the patient is not going to be there, is no more. Now, obviously, the question comes very often at this point, Dr. Saab, what do we do after this? This is the time, obviously, based on each patient's discussion and what gut feeling I have with the communication with them, I broach the topic of organ donation if I feel that these people may be receptive about it. I say that there is one option, you can actually consider organ donation. We talk a little bit about organ donation to the family, and we tell them that this will only be possible once the second test is completed. Only then we will be able to certify the patient as brain dead, and then we can think of organ donation. But this is one of the options that we do. Trust me, majority of the patients take a long time to decide, and number of discussions, number of detailed explanations to them has to be done. You have to spend a lot of time. Organ donation is about spending time with the family. Time, nothing else. If the more you spend the time, the more likely that the patient will understand what you are talking about and they will actually consent for it. So once the second test is done, the apnea test, end of the apnea test, end of the second apnea test becomes the time of death. The time of death is the end of the second apnea test, not when the heart stops in the operation theater, not when the heart stops if the family consent, does not consent for organ donation. It is the time of the death is basically the second apnea test which we talk about. And we say to the family that I have already declared the patient dead by brainstem death criteria. At that point, when you have completed the second test, it is imperative that all doctors say that patient is dead, no more. If you start saying that the patient is brain dead, somebody in the family will think brain is dead, but the rest of it is working. So you need to be very clear the terminologies which we use, the language which we use. It has to be crystal clear to the family to understand that this patient is no more. Some of the observations compatible and incompatible with brain death: spinal reflexes, sweating, blushing, tachycardia, normotension without pharmacological support, absence of diabetes insipidus are all compatible. What is incompatible? Any kind of posturing, cerebrate, decerebrate or decorticate, extensor or flexor motor response to painful stimulus, or seizures are not compatible with brain dead. So if you see any of these, just step back and say that those patient is not brain dead. So you should be aware what is compatible, what is not compatible. In the literature outside India, some of these tests are called as confirmatory tests. As I said, they don't actually mandate us in the law. In fact, they do not recognize this in the law. The poorest of the confirmatory tests is EEG, which unfortunately happens to be the most commonly done. I get calls from neurologists all the time. EEG is flat. Well, EEG, there is a different technique to do it. Some neurologists are aware of that technique. They need to bring down the voltage sensitivity very, very low to actually do a EEG for a brainstem death patient. A transcranial Doppler, again, is very user specific and it only looks at the middle cerebral artery flow, does not look at the other artery flows. So it's not recommended. But the most common one which can be done is a CT angiography or a conventional 4-vessel DSA, which are the gold standards if you have to do something to basically convince yourself. Again, I am repeating, this is not mandated by the law. Now, there are some conditions in which unfortunately you will not be able to do a clinical brainstem death testing. For example, if you have a high spinal fracture, which is above the C3, so above the C4, involving C1, C2 or C3, remember the diaphragmatic innervation are below C3. So if you have something which is cut off from above, you will not be able to do an apnea test because the patient will not be able to breathe. So you will not be able to do a clinical brainstem testing. Similarly, if you have got raccoon's eye, you're not able to look at the pupillary reflex, you have base of skull fracture with the otorrhea, CSF otorrhea, you may not be able to do a cold caloric test. I think in these conditions, apnea test becomes a challenge or a clinical examination becomes a challenge. And you may choose to then use one of these ancillary tests along with that. But as I said, law does not allow it. So currently, as it stays, we do not recommend that to be done because we will not be basically able to diagnose brain death with that. But I think the law will change. There will be some additions to that in some stage over the next few years, where in such conditions, we may be able to use CT angiography as an additional test. Whatever test you can do, you should do, and an additional test to sort of use CT angiography for confirming brain death. These are just some of the pictures. Here you can see the empty skull sign on the left. There you can see a complete cutoff after the internal carotid. You can see no circulation in the brain there. This is a cerebral perfusion scan. Some of you can do a cerebral perfusion scan as well, nucleotide scan. Here again, an empty skull sign, which is seen, which shows that there is no circulation in the brain at all. So this is how you diagnose the patient brain dead. This is how you communicate with them a little bit. I can take a minute's break if Archana madam says, and I can take some questions on this part, or you want me to finish the donor maintenance also?
So we can complete, because as of now I'm not seeing any questions in the chat box. So we can complete the second part and take all together.
Sure. So now the most important thing is that if you've taken the efforts to actually go across and diagnose patient dead, then you should be essentially able to maintain those organs so that they can then be. Hello.
Yes, sir. May I just interrupt for a second?
Sure.
Just for the benefit of our listeners, one basic thing which I'm going to be putting over here. Can you please elaborate why are we talking of brainstem death in context with organ donation?
Okay. So if we are going to talk about organ donation, there are two ways in which organ donation happens. One is a live related concept, which everybody knows, that liver and kidney can be donated. Part of it can be donated from liver, and one kidney obviously can be donated to your near and dear one. However, there are organs like heart, lung, pancreas, intestine, uterus, hands, which unfortunately cannot be donated by a living person to another person. So you require to have a mechanism in which, if you have an opportunity to take these organs for helping somebody who has got an end organ failure, then the only way possible is to actually look at patients who have got a irreversible injury of the brain, which we call as brain stem death. And to maintain that and to understand that, we need to understand how do we actually do a brain stem death. And for this, the Organ Donation Act, the Transplantation of Human Organ Act of 1994 came into existence in India. And based on that act, they have defined two types of death: circulatory death as well as death by brainstem death criteria. So you should be aware that every patient who has a death can have death by these two criteria. And if the circulatory criteria is understood by everybody, the brainstem death criteria needs to be understood by the doctors first, so that they can actually explain it to the patient. And when you have that with the modern ICUs, you have an opportunity where, with the ventilator going on, some of the organs like heart, lung, liver, kidney, uterus, hands, skin, eyes, tissues as well, they may continue to have good function before eventually the cardiac system stops as well. And within that span of time, if the patient is diagnosed as brainstem death and declared brain dead, then if the family consents for it, his or her organs can be retrieved and transplanted into other living patients.
Thank you so much, sir. So now we can move on to the second.
Okay, all right. So how do you manage brainstem death patient until the organ retrieval happens? I would say a general approach to these issues is good. Just practice good housekeeping, use your standard approaches to the problems, maintain organ perfusion, prevent adverse sequelae of the brain death, correct abnormal physiology, exclude contraindications to donation, and consult an organ donation agency like ZTCC anytime. So what happens is that before the patient was diagnosed as brain death, our treatments are oriented at maintaining a mean arterial pressure, cerebral perfusion pressure. We give them osmotherapy, we do temperature control. All of these therapies are there. But once you have diagnosed the patient brain dead, withdraw these therapies and come up to therapies where you will have extracranial organs being supported well. That means good perfusion for the kidney, good perfusion for the lungs or heart. Those are the things which are important. The brain obviously is now become dead, so your therapy should not be targeting around that. I generally follow a rule of 100. And if you are able to maintain a patient with this rule of 100, most patients will be absolutely fine. So systolic arterial pressure of 100 millimeters of mercury, urine output of 100 ml per hour, PaO2 of 100 millimeters of mercury and above, hemoglobin concentration of 100 grams per liter, which comes to around 10 grams per deciliter, blood glucose of 100 milligrams per deciliter. I can add two more hundreds to it, temperature as close to 100 as possible, that means 98 degrees Fahrenheit, and saturation as close to 100 as possible. So these are the two more hundreds I can add for it, but these are the rule of 100 which you should use. So rule of 100 makes you very easy. You just need to maintain the physiology within these numbers. We have Indian Society of Critical Care Medicine statement published way back in 2015, where it gives you a full description of what are the physiological changes which happen with brain death and how you need to basically support each of them. There are recommendations for managing respiratory care, circulatory care, prevention and treatment of hypothermia, diabetes insipidus, nutrition, coagulopathy, and management of patient during the organ retrieval. All of that has been given, and those are the I'm the first author for that paper, and whatever I have got it on this slides is an exact transcript of what I've written in the paper. So respiratory care, your routine respiratory care should continue. You should be able to give PEEP. You should be able to do chest physiotherapy, recruitment maneuvers, avoid interstitial fluid overload so that adequate oxygenation is maintained. And it is very important that you keep the patient very, very clear of infection, so that if the patient is going for a lung transplantation, then the optimized utilization of the lungs can happen for a successful transplantation. Circulation, I think autonomic storm, which happens when the patient is phoning, is usually transient. And at that time, you obviously have not diagnosed the patient brainstem death. So short-acting agents to see for the hypertension like esmolol or sodium nitroprusside can be used. You need to correct your arrhythmias, electrolytes, volume and temperature, and drugs which you would normally use by doing correction of potassium, correction of magnesium, give adequate volume, make sure the patient is warm. If you need to use antiarrhythmic drugs like amiodarone or lignocaine, go ahead and use. You can treat the arrhythmias as required. Bradycardia can also present and pose a problem. So adrenaline, atropine, isoprenaline may be effective in controlling the heart rate and bringing it back to a normal range. If the patient has already been diagnosed as brain death and is awaiting retrieval of organ and has a cardiac arrest, a CPR can be given to these patients, and you can still have a successful resuscitation and a successful transplantation post that. How do you correct volume? Well, volume should be optimized by administration of IV fluids. We always use dynamic measures of fluid assessment, such as the IVC or passive fluid raising, or we look at stroke volume variation on the monitor. We do not just go by CVP at all. Competing requirements for optimized organ function may have conflicting strategies. I will give you an example. If I have a patient who has potential of donating his kidney as well as his lungs, the kidney doctors usually want the patient to be optimally filled, whereas the lung doctors want the patient to be as dry as possible. So you need to come to a middle point where you are satisfying both of their requirements, because if you give a patient who is overloaded, the lungs may not be good. If you give a patient who is very dry, the kidney may not work as well as you had intended for it to work. It is important that you identify which organs are going to be transplanted most likely. If the patient already has a creatinine of 3 or 4, unlikely that the kidneys will be taken. So concentrate on the lungs. Similarly, if the patient already has got some lung patch and there is a query about pneumonia, unlikely that the lungs will be taken. Obviously, the final decision is taken by the team which transplants. Your job as an intensivist is to look after this patient, not bother what they are taking, but it might just make your decision making easier. Usually, most patients will require inotropic support. Almost 85% of the patients require noradrenaline. Nowadays, our first vasopressor of choice is not noradrenaline for brain dead patients, but it is vasopressin. Vasopressin given in 1 to 2 units per hour takes two things for us. It helps us in restoring the circulation. It also helps us in restoring the diabetes insipidus, which happens because of lack of vasopressin and because of which large volume of urine is secreted out. by the patient. So first inotrope of choice is vasopressin. However, most of them patients will require noradrenaline in support of that. Hormonal resuscitation, there is no level 1 or level 2 evidence to endorse the use. However, patients who have persistent hemodynamic instability and would have a ejection fraction of less than 45%, then an intravenous T3 or T3 can be given 4 milligrams. Now, this is a big problem. Intravenous T3 is not available in India. So what we do is we just give thyroxine 300 micrograms tablet through the nasogastric tube, and we hope that it is absorbed. Remember, these patients also have got absorption problem and gastroparesis. So you may hope that it is absorbed, but whether it is absorbed or not, we don't know. A low dose steroids can be given for any patient who is hypotensive, but if the patient is likely to go for a lung transplantation, the lungs are likely to be donated, then give them 15 milligram per kilogram of methylprednisolone. Lung is the powerhouse of all the cytokines in the body, and to suppress that, a large dose of methylprednisolone can be given to this donor so that the transplantation happens very nicely. As I said, diabetes insipidus is a problem. Invariably, these patients will have large volumes of urine being poured out, sometimes up to a liter. We always start vasopressin nowadays. 0.5 to 2 units per hour for an adult patient is usually enough. We need to do simultaneous volume replacement to make sure that the patient does not become hypovolemic because of large diuresis. Within an hour or two of vasopressin being started, diabetes insipidus usually is controlled well and it stops. Similarly, metabolic derangements like sodium and potassium should be checked every 2 to 4 hours and make sure that you replace them as required or you correct them as required. Hypothermia is one of the biggest problems. As I said, the temperature control mechanism is lost, the shivering mechanism is lost, so patients become very easily hypothermic. It's easier to prevent hypothermia. That's why it's very important to identify the brain dead donors. One of the easy things which I do nowadays is I look at the mnemonic GIVE. G for Glasgow Coma Scale less than 5, I for intubated, V for patient who is on a ventilator, and E for patient who has got abnormal or absent eye signs. These are patients who can become potentially hypothermic and can become potentially brain dead. So I tell the bedside nurse, watch out for hypothermia, insert a core temperature proactively in these patients so that when the temperature does stop dropping down, not only it tells you that this patient may have actually worsened and become brain dead, but it is also easier for the nurse to obviously start warming precautions beforehand. Because once the patient becomes hypothermic, to bring them back to a temperature of 36 or 37 degrees Fahrenheit is a huge task. You will find several hours before they become normothermic. And while they warm up, they invariably vasodilate and become more hemodynamically unstable. So you should prevent hypothermia rather than actually allowing it to happen. Anemia and coagulopathy, nothing spectacular in that. You should correct anemia and coagulopathy as you would normally do. Our ICU transfusion targets are 7 grams per deciliter, and our coagulation factors as required, transfusion factors as required, platelets, if they are below 40,000, you should give them, because if the patient is going for a surgery, better to keep the platelets above 40,000 because it's a supramajor surgery for the donor. Though the donor is brain dead, the cut and the bleeding mechanism is still going to be the same. Nutrition, continue enteral feeds. There is no reason to stop the feeds. Gastric stasis can be sort of tempered, where it can be attended by giving either prokinetics or aspirating, and then again starting the feeds at a shorter interval. During the organ donation, anesthetists should ensure adequate monitoring. Blood products should be available. Normal ventilatory and circulatory parameters should be used. Remember now, anesthesiologists may require to give neuromuscular blocking drugs. The reason being, the entire incision is below the neck from the suprasternal notch to the pubic symphysis, which is at the spinal dermatome level. So you don't want some spinal reflexes to be elicited while the operation is being done. You should not see any muscle twitching or flickering, and that may actually cause a lot of distress to the surgeon. So please use neuromuscular blocking drugs. Sympathetic responses could result in myocardial injury and exacerbated bleedings, and opioids can also be sometimes used. If you have a severe oxygenation failure, try and diagnose what the problem is and see if the lung function can be improved. Spinal reflexes, always make sure that spinal reflexes are discussed with the family, especially warn them that these are the spinal reflexes which are seen because the spine is actually intact with the brain which is dead. And Once the patient's organs are donated, please extubate the patient in the operation theater and bring them back to the ICU in a nice way so that the family can actually wish them goodbye before you hand over the body to the patient. Some reassurance do usually what you would normally do in normal situations. The problem very often occurs that if the patient becomes brain dead, the ICU doctors and nurses give a little less attention to those patients. So give your full attention as you would normally give to any patient. Usual visual and attention is required. Approach to the problem stands systematically. Usually serious problems are uncommon, and if required anywhere in the country, I am available to give any help at any time on this topic. With this, thank you very much. I'll be happy to take questions.
Thank you, sir. Thank you for that wonderfully elaborate session. I think the things should be very, very much clear to all the participants. I request anybody who has got questions, please put them in the chat box, or you may raise your hand and we'll take them up for you. Sir, before we move on to Dr. Shivpujji, who has raised hand over here, something which you mentioned in your this talk, what I want to ask is about the panel of doctors who certify this brain death. Okay, for the benefit of the people who are attending, can any hospital certify? Can any hospital have this panel of doctors? Can anybody talk about brain deaths?
So the hospital needs to be certified as an NTORC, non-organ transplant retrieval center, or a transplant center. And within those, the doctors need to be identified that they are either a neurologist, intensivist, or a neurosurgeon. Generally, these are the four. Physician can also be there. Pediatrician can also be there. And that list needs to be approved by the DHS in Maharashtra. So that those are the doctors who can then go and verify and certify these patients as brain death. So you require a hospital which is recognized, as well as you require a panel of doctor within that hospital which is recognized. If your hospital is not recognized, there are two ways out of which. One is you shift the donor to the nearest NTORC or the transplant center. Or technically, now this is technical, I am sure you may have DHS people on the panel right now. Technically, emergency permission can be given, but those are technical things. I am not a government person. There may be having genuine difficulties in that. I should not be commenting on it. But technically, it can be given, I think. But it is something which they have to. So they can give a permission for the hospital, but they cannot give a permission for the panel of doctors, because suddenly you can't say that these doctors are capable. The doctors will still have to come from a transplant center to help. This is technically there. The easiest way is to shift the patient to a donor center or an NTORC.
Great. So just for the benefit of all the people who are listening, our next session next month, which we are planning to take, is how to register your hospital. What are the criteria to register as NTORC? We'll be sending the details out soon. So I invite Dr. Vijay Shivpujji to ask his question. Sir, please unmute yourself and ask your question.
Dr. Pandit, you have nicely elaborated the process of organ donation. I have a few queries. Is there a role of prophylactic antibiotic while patient is waiting for the?
There is no role for prophylactic antibiotics, sir. If the patient requires antibiotic for a clinical reason, please give it. Otherwise, no role for prophylactic antibiotic.
Yeah. And in case of a patient who is having a polytrauma, suppose a patient is having a head injury as well as a lung injury or lung contusion, can the organs, traumatic organs, can be retrieved?
So head injury means the patient will be brain dead.
Brain dead,
now,
yes.
whether the lungs are good for retrieval or not, as I said, the final decision I leave it to the surgeon or the surgical team which is coming. We should go in the mind that whichever organs can be salvaged and can be saved and can be preserved, we should go ahead with it. Many times, Vijay sir, I have seen heart looks fine on the echo, everything. When they open up, they find that the coronaries are completely calcified. They have rejected organs on table also. Yeah. So it is very difficult. So I actually counsel the family that the final decision is not by hands which organs will be taken. It is in the surgeon's hand whether the organ will be taken or not.
Because in a grade 1 liver injury, which is physiologically normally functioning liver, healthy liver, but having a grade 1 liver injury, can this liver be retrieved?
Yes, sir, it can be retrieved because liver is such an organ where you could actually leave that injured part out and transplant the liver. So even half a liver for a person would still give him the life, which we do normally anyway. The split liver transplant is what we do on a live related anyways.
And last question, sir, is there any role of low molecular weight heparin prophylactically?
DVT prophylaxis should continue for all patients unless it is contraindicated. But once the patient has been diagnosed brain dead, please continue DVT prophylaxis unless the patient has got low platelets or coagulopathy already, where the bleeding risk could increase.
Yeah. Thank you, sir. And last question, if you permit.
Sure, sir.
In case, unfortunately, patients land in hypothermia and otherwise patient is a good candidate for a donation, how to correct the hypothermia?
So there are two or three ways in which you can do it. First is obviously surface warming, which we all of us do. We put a blanket. There are bear huggers which are available, where bear hugger blankets, you can give warm 44 degrees warm air through the blanket and you can actually warm them. That's surface cooling. We give them IV fluids. We can give them warm tepid saline washes through the nasogastric tube as well as through bladder washes. And then third, these are not available in India. I have not seen, but I have used them extensively in Australia. You have warming catheters which can be placed as a IG in the internal jugular or in the femoral vein, and you can actually run them through a warmer circuit where fluid just circulates within the catheter, and the catheter has got a thermostat type of a probe outside which warms the blood locally. So these are the three ways in which you can do it. Usually with us, we are very happy with surface cooling as well as with warm IV fluids being given. And usually
can warm fluid be given through the rice tube and or
warm
warm
fluids can be
saline?
given through the rice tube. Warm fluids can be given intravenously. Just make sure you put few drops on your skin and make sure it is not hot. It is not hot. That's all.
Thank you, sir.
Yes. So I invite Dr. Borges to ask question. Dr. Borges, please unmute yourself and ask your question. Please unmute yourself. Okay, till then I move to Dr. Kamath. Please unmute yourself and ask your question.
Hello, sir.
Hi.
Hello. So I had two questions. The first one was if the patient, while we are doing the apnea test, if the patient becomes hemodynamically unstable or rather even has a CRA, so and we revive the patient later subsequently.
What does the patient in CRE? Sorry, what
the cardiorespiratory arrest? During
okay.
the apnea test, if the patient has an arrest and we revive the patient, but how long we should wait to do the next test, the apnea test?
Look, it all depends on how the hemodynamics of the patient are. So as I said, you want the physiology to be as close to normal as possible. If the patient becomes hemodynamically unstable, there is a way of actually proactively putting these patients on noradrenaline or adrenaline so that they don't become too hemodynamically unstable. But let's say, unfortunately, they do become unstable and become very unstable or have a cardiac arrest. There is no time frame which can be given in a particular scenario. You have to go case by case. When you feel that this patient is hemodynamically robust now to tolerate another apnea test, that is when you should go for it.
Okay. Sir, is there any specific dose for the inotropes? Like if the patient goes on very high doses, then we cannot do the apnea test. Is it any clause like that?
If the patient is more than 0.7, 0.8 mics per kg per minute, usually these patients are extremely difficult to do apnea test and disconnect from the ventilator. In that case, we add one more inotrope, balance it out a little bit, give fluids at times. In a very rare situation, we may have to abandon it and not just go ahead with it. But trust me, if you have kept the patient warm, if you've corrected the electrolytes on time, if you have made sure that the inotropes were started on time, or did not allow the patient to lose large volume of fluids through diabetes insipidus by starting them early on vasopressin, these patients maintain very well. Core temperature is the most important thing. Quite often, I see that patients are not being measured with the core temperature, and surface temperature is being kept, and people keep on saying patient is warm, and that is one of the biggest causes for hemodynamic instability.
Okay, thank you, sir.
Yes, I invite Dr. Natalina Borges to ask question. Dr. Borges, you want to ask any question? Please unmute yourself and ask your question. Okay, I invite Dr. Sushma Malik to ask a question.
Good afternoon, sir. It was an excellent lecture. I just want to know, sir, do you have any experience or have you come across any patient from the pediatric or the neonatal, especially the neonatal age group, for organ transplants? Has it come up in India, especially in Mumbai?
So organ transplant or brain dead donation?
Brain dead donation. Brain dead donation.
Yes, several pediatric children have had brain dead been declared and donated.
Okay.
I am an adult intensivist. So
I know, sir. Yes, sir.
But our pediatricians are very well capable of doing that and going ahead with donation. Neonatal, I am not aware in my hospital, but it is not difficult. It is not different anyways. Only difference is that between the two tests, you need to give as much long time as you can. In an adult, we give 6 hours. For a neonate, sometimes we have to wait up to 48 hours. Because remember, in a neonate, the brain, which is a fixed compartment, is not true because the fontanelles are open, and because the fontanelles are open, the ICP may not be actually very high at times. So you need to give two intervals as much as you can. I'm happy that I'm not a neonatologist.
Okay, thank you, sir. Thank you.
Okay, so I think Dr. Borges is unable to unmute us, or rather unmute herself and ask a question. So with this, we come to the end of this session, and Dr. Pandit, really, it has been a very, very elaborate session, and you have made things, I think, very, very simple for our delegates to understand. And so it's a sincere request to all the people who are attending today's session that we really, as medical professionals, we need to understand and we need to promote organ donation as much as possible to make lives better for people who need it, really badly. So we thank Rahul Pandit sir for this session, and on behalf of IMA Maharashtra State, I present. Is my screen visible? Just a second. Screen. Yes. The certificate of appreciation to Dr. Rahul Pandit for taking this excellent session on identification of potential brain dead donors and maintenance of brain dead donors during this organ donation awareness program, Train the Saviors, organized by IMA Maharashtra State Organ Donation Committee in association with Roto Soto today on 23rd of March 2022. So thank you so much, sir. And I sincerely thank Fortis Hospital for educational grant for this program. So with this, we move on to our next session. That is, now that we probably know in our ICU, we are seeing that we have a patient who is potentially brain dead, and you have informed, you have rather a team of doctors who are feeling that yes, this potentially brain dead patient can become a potentially potentially an organ donor. So now how do you contact the coordinating agencies? Because as we know, organs cannot be directly donated, or they cannot be directly transplanted. So we now need to inform the coordinating agency for starting the further process. For this, we have Ms. Sujata Ashtekar with us, who is the central coordinator of ZTCC, to talk about when and how to contact the coordinating agencies. Okay, so for this, allow me to introduce our speaker. Just 1 minute. So, Ms. Sujata Ashtekar, she's consultant IEC Roto Soto, Maharashtra and West. She's chairperson for awareness activities ZTCC, and she came in the field of organ donation in 1998 when she was appointed as transplant coordinator in Jaslok Hospital. So I invite now Ms. Sujata Ashtekar to please take this session forward. Madam?
Yes. Thank you, madam. I think I'm audible now.
Yes, yes, madam, you are.
Now we are taking this further after excellent session from Dr. Rahul Pandit, as always, about basics of declaring brain death and donor maintenance. The next step is about informing to the ZTCCs or the coordinating agencies. I'm just sharing my screen for the presentation. Is it visible?
Yes, ma'am. If you can just make it full screen. Yeah.
So the topic given to me is when and how to inform the coordinating agencies if there is a potential brain dead donor in the hospital. Now, this we will more relate to the hospitals which are not registered for transplant and which are not registered as a NTRC, non-organ transplant retrieval centers. So we have around 100 transplant hospitals in Maharashtra. So if we have a donor in those 110 hospitals, then even if they are registered for kidney transplant, for retrieval by law, they can retrieve all the other organs. So we do not need any special permission. And for brain death, the declaration team is already existing in that hospital. So only depending on the consent, the organ will be retrieved. For NTRC, we have around 60 NTRCs in Maharashtra. The scenario will be little different because they have nothing to do with transplantation. So those are the hospitals who are only doing retrieval. So there are only few of these registered NTRCs who are very much used to doing donations. So that is because of the team which is very much motivated. And apart from that, we may not have the hospital which is so experienced in doing donation. So unless it is a transplant center and it's not an it's a NTRC, if what to do if there is a donor in a small setup which has an ICU and brain death can be declared. So we have to contact the coordinating agency. Now we cannot declare brain death in an ICU, which hospital, if the hospital is not registered. But because of the awareness, or we want more and more donations happening here, and it is considered the duty of the ICU doctor to request the family for organ donation. So we, as a part of our social responsibility, if we come across the case where we can motivate and have the donations, how to go about it. So there are coordinating agencies established by the state as well as by the central ministry. So in the state, right way back in 2000, zonal transplant coordination centers were established. The first of which was in Mumbai, and it is Mumbai at Sion Hospital. So these are the centers which actually distribute the organs, and it is a duty of the hospital to inform them first if there is a brain dead donor in their hospital. So whether it's a transplant hospital, whether it's an NTRC, and if it is none of these, but there is a donor, potential donor in the hospital, then Zonal Transplant Coordination Center of Mumbai has to be contacted. There are 4 ZTCs, Pune, Aurangabad, Nagpur. So the respective zone ZTCC has to be contacted, and we have to inform them that there is a possibility of organ donation or a potential donor within our hospital. Apart from that, at state level, there are regional cum state organ and tissue transplant organization, Roto Soto, Western Maharashtra. If you contact Roto Soto, they will contact the respective ZTCs. Or NOTO is also existing, so National Organ Tissue Transplant Organization. So even we many times get the calls from NOTO helpline numbers for our region. So any of these organizations you contact, ultimately the call will go to ZTCC of that particular zone. So the ZTCC coordinator, once knowing that there is a possibility of a brain dead patient in a particular hospital, then they will first see that whether this patient is likely to be a brain dead. So they will talk to the intensivist and send the transplant coordinator from the nearby hospital, which is a registered hospital, to this hospital for counseling. For example, say there is a potential donor in New Mumbai hospital, then they will say send someone from Apollo or the hospital which is very regularly doing donations, or say from Mulund Thana area, then Fortis Jupiter. So accordingly, they will decide which coordinator to go. Please do not contact the hospitals directly, because it's a role of the ZTCC to send the respective transplant coordinator to a particular hospital where there is likely to be a potential donor. And if patient family is already willing for organ donation, then we can proceed further for shifting protocol. So if many times we get a call saying that hamare paas donor hai and family is willing hai, and when we actually try to speak to the family, they have no clue what they have said yes to. They don't know what is brain death, they know what is organ donation, and the relative, it's what they say is not actually a close relative. So we need the consent from the close relatives. So उन्होंने मामा से बात की होती है या चाचा से बात की होती है. So in that case, taking a step like shifting the donor is something we have to be very, very, very careful about. So who exactly are present with the family, that is what the ZTCC will find out. Then patient shifting can be done only after transplant center doctor is convinced that the patient is a potential BSD and suitable for organ donation. So many times the nearest transplant center doctors will speak to the intensivist where the potential donor is, and they will take the history and they will know from that whether this patient is brain dead. And many times an intensivist or a brain death committee member from a registered transplant center will go to that nearby hospital, will see the patient himself, and he feels that this can be a potential donor, and then move on. In many times in the past, we have been to the hospital and we have found that some reflexes are still present. So forget about apnea. So this patient cannot be considered for and shifting for organ donation. So family needs to be counseled accordingly. Then we have to be very clearly telling the family that anything can happen during shifting. Many times we have lost donors on the way. So the recipient hospital is also very clearly informed that if something happens, they have to, while shifting the donor, if the patient has cardiac arrest, unfortunately, on the way, then they have to take the responsibility of giving the death certificate and doing the further procedure. Then family has to clear the previous hospital bill for which from where they are the shifting. So it's not that they're shifting for organ donation, so the hospital bill will not be paid. So they have to shift the bill, and the recipient hospital may not charge because they're shifting for donation. So whole process will take minimum 24 to 48 hours, and the timing depend on case to case basis. So we have to tell the family that how long it will take. Secondly, very clearly in clear terms, we also tell the family members that, see, we are very happy that you want to shift the donor for saving lives, and you are really contributing, but at the same time, after shifting only we will know whether this patient is brain dead or not, because we cannot declare brain death in a unregistered hospital. So even if we know off the record this patient is likely to be brain dead after seeing by the intensivist, there is always a possibility that after shifting, when the 4 doctors actually do the apnea test, they find that this patient is not brain dead, and this has happened in the past. So the relatives are counseled for the same, that it is possible that patient may not be brain dead. And if it is a medical legal case, then police NOC is required, and also the postmortem is needed, which can take some time. So all that is informed to the family, and by now you must have understood the families who are really very, very well motivated only go further and agrees for shifting the donor. So it is, what are the protocols of the coordinating agency? I'm sharing the protocols of ZTCC Mumbai, that the donor will be shifted from non-recognized center to recognized center. We do it zone wise. The Mumbai region has been divided into different zones. So that's why we say that you don't directly contact the big hospital. The ZTCC will decide which hospital to be contacted. So it is the South Mumbai, Central Mumbai, Northern Mumbai, Western Mumbai. So that is how they have divided the whole Mumbai and the hospitals under which these transplant centers are, and the call will go, and within that zone also, there will be many hospitals. So the ZTCC takes alphabetical rotation, and it is understood that if the hospital is coming forward and shifting the donor, then that particular hospital, the hospital which is taking the donor inside, will get one organ of their choice. So that is the motivation for them to go ahead and shift the donor to their hospital. So mostly they see that the hospital is also experienced when we at all shift the donor, because if we don't shift it to the experienced hospital, the relatives will suffer, because again we have to explain everything and it may cause delay. So we don't want that. That's why, and these are very, very motivated families, and they are anyway going extra mile for organ donation. So we don't want any further problems occurring. So we generally shift them to the experienced hospital. When the call comes, we also ask the hospital to give us the treating doctor numbers so that the team of the ZTCC can speak telephonically. So many things can be sorted out telephonically. Then contact number of the next of the kin. I again repeat that we do not get it. We many times get the number of the relative who is present, but that person may not be the next of the kin. So we need to have some telephonic conversation with the next of the kin, and if required, going there and talking to them. We also request a letter from the hospital head for the shifting. So in that letter, the hospital where there is a donor has to officially inform that we have a patient in our ICU with these conditions. Please, we don't have to mention brain death there, because we don't know whether that patient is brain dead legally. So we just say that it's under this condition and family is willing for organ donation. So we kindly guide us for the further process. So that mail is required. And as Dr. Rahul Pandit was saying, many times we from ZTCC also approach DHAs for giving one-time permission to that hospital. Sometimes it may happen, sometimes it may not happen. And as he very correctly said, the option and the easier option is to shift the donor to the nearest hospital, because the hospital which is actually involved in shifting will send the ambulance, the team will go, their trained transplant coordinator who is much more experienced will go and will shift the donor. And if it is the nearby hospital, family also will be a bit comfortable shifting. Suppose someone from Virar, if I try to shift to CST, then it's a problem. But for Virar to Borivali or Thana, they may be okay. So need minimum 3 to hours, 4 hours for coordination with the hospital. Suppose someone gives us the call that we have a potential donor and the family is willing, then we need 3 to 4 hours to contact the hospitals, take the history and do all the paperwork till we ship the donor. So that much has to be given to the coordinating agency. And the whole organ donation process 24 to 48 hours. And we cannot give the specific time. Most of us keep telling family that, we don't ask us the time. We generally give them some time, like maybe 10 o'clock tomorrow. But we also at the same time again and again keep repeating that there are many factors. So it may get extended even by 4-5 hours. So I remember in one of the cases, I had informed family that I'll be giving body at 8:30 in the morning, and I gave it at 6 o'clock in the evening. So they knew what was going on. So they were not angry because we kept them in loop in what was happening. They knew that, there was some delay at the police procedure. There was some genuine delay because the teams were coming from other cities. So if we keep them in loop, then they understand if we are genuine. So process also depends on clinical condition of the patient. So what do we generally ask? In today's scenario, we asked about COVID test, because there is no point in going ahead. We do not have the patient's COVID RT-PCR of 24 to 48 hours. Then only the whole process of shifting we can think of. That doesn't mean that we don't talk to the family. We keep on continuously talking to the family, talking to the doctors, but we need RT-PCR before we take the decision of shifting the donor. Because if we shift the donor, and this has happened also once, if shift the donor and we find out that a patient turns out to be COVID positive, then it's a problem. So we need RT-PCR within 24 to 48 hours. Then brain CT to establish the cause of death. HRCT, admission notes that can be shared before shifting. Clinical history and medical summary, yes, very much can be given before shifting. Then ICU chart, investigations charts, imaging, whatever histopathology, endoscopies, and other reports relevant to the case. LFTs, RFTs, if they are done, complete blood count, blood group report, viral markers, urine routine, urine protein. So these are some of the basic tests which we require before shifting, and we find that mostly these tests are done. Otherwise we cannot shift the donor, but it does not mean that if some of this is missing, other than like COVID and infection tests, then we can shift the donor and the test will be done at the recipient hospital, and the donor family will not be charged for the same. So I'm sharing the contact numbers of the coordinating agencies, Noto, Rotosoto, and ZTCC Mumbai. ZTCC Mumbai is one of the grassroots organization with whom you have to make the contact. So if you can take the photograph of ZTCC number, then it will be helpful. So shifting the donor is one of the options which we have tried in the past. Yes, there are problems in the process, but we have done many donations with this process. And it is not that if the patient is not in a registered hospital, we cannot do the donation. We can still do the donation. And if the family is motivated, they agree to it. So thank you. And if any questions, then I will.
Yes, thank you so much, madam. So I'll just, the points which you have said, that the brain death cannot be declared at a non-NTORC hospital. So if any patient, the doctor feels in their ICU, if it is not a registered hospital, and if they feel that this patient may be a potentially brain dead donor, then they are supposed to contact ZTCC. ZTCC
Yes,
will be sending the coordinator, and that coordinator will be coordinating with the patient's relatives.
yes, ma'am.
Right. And the patient will be shifted to a hospital which is meant for transplant. So now,
Yes.
madam, what my question would be that now once probably this coordinator has come, they have spoken to the patient's relatives, probably they have understood the possibility that there is a possibility of brain death, which now Dr. Borade will elaborate on, that how to talk to the relatives if you think that there is a potential brain death, and how to talk when there is a confirmed brain death. So that will be coming to that later. But once you say that there is a potential brain death, the ZTCC people have come and the coordinator talks to the relatives. Who bears the expenses thereon? I mean, now the patient that will have to be shifted to a transplant center. And the transplant centers, these will be the tertiary care hospitals, wherein the patient is going to be on a ventilator, and there will be like lots of logistics which will be involved. So what will be what about the cost of the treatment?
The shifting, see, as I mentioned clearly, till the donor is shifted, they have to pay the bill of the hospital from where they are getting transferred. But once they get transferred to the new hospital, which is a transplant center, they will not be charged. So the hospital will be taking care of it.
So even if it is still a potential donor?
Yes. And that is very much made clear to the
relatives
and the relatives, and then only we shift. If the hospital is not willing, then that has to be informed that, you may have to pay if the brain death is not declared, because that has happened in the past. So whatever it is very clearly, we generally shift to a donor and do not charge the family. Otherwise, we have to very clearly inform them that if the patient is not brain dead, then we may have to charge. And in that case, the ZTCC takes the stand very, very clearly on it. And they may have to pay if hospital refuses. But before shifting only, all these things are clarified. And if a patient is brain dead in other hospitals also, I mean in the transplant center, say private hospital, then from first apnea, after the consent. If there is no consent, then family has to pay the bill because there is no question of organ donation. But if there is no consent and but if there is a consent and the first apnea is done, after that, all the tests which are done for the cause of organ donation, the family is not charged. So we'll end there. So the same logic applies here.
And madam, what about the cost of transport? What about transport in the cardiac
That is the
ambulance?
recipient hospital.
Acha, that will be the recipient.
Yeah,
Hospital. Okay. So, okay, we have Dr. Alka Kuthe who's raised hand. So, madam, please unmute yourself and ask a question.
Yeah, thank you, Dr. Archana. Madam, excellent lecture. You have provided us a very excellent tips how we should do transfer the patient. My question, actually, half of the question you have answered, but still there is some dilemma in mind. The potential donor can be from government hospital also, or it's only from private hospital?
Yes, it can be from government hospital, madam. We have shifted one donor from government hospital to private to public hospital. The public
Then the
hospital.
question is related to that many times is viral markers and many tests, they are not available in government hospital.
Then we do it at the recipient hospital, madam.
Yeah, okay, but who will?
Depends on case to case. If we feel that the patient is likely to be brain dead, and the team which comes there feels strongly that yes, this patient is likely to be brain dead, then they will do the test and they will not wait for the test. Then they will,
because the patient has come to
1
government
o'clock in the night, it is difficult, na madam, to decide on.
But because the patient has come to government hospital because of the economy, poor economy. So the expenses of the investigations like viral markers, LFT, GAPT, etc. Probably the family will not be willing or will not be able to do those investigations. So in that case, whether the transferring hospital or the recipient hospital will bear the expenses?
Yes, they will bear the expenses, madam, whatever is asked for.
Yeah, because government
transferred, but we generally it is on the recipient, the hospital where it is gets transferred, we do the expenses or the ZTCC will provide.
Okay, and then my
but
second
most of the investigations in public hospital, madam, in KM hospital, when we do, they are available in house. So
Yes.
if they don't have something very, these are the basic investigations which are very much available in house, even in KM hospital, because in KM hospital, when we do the test, I always make a call to the president ZTCC, sir, in suppose we have to do something out of out the test which we cannot do and we immediately reason, will ZTCC help? And I'm very sure they always say yes, but I have never actually approach them for the money because most of the tests are done in the government hospital. Basically,
actually, there's a provision of Mahalab. Mahalab means there's some special laboratory which contains all these remaining tests. So most of them are performed, but there are few tests which are not performed by them yet, in spite of availability of Mahalab facility.
Yes, then either the ZTCC that can be sorted out before we actually go ahead with on the case-to-case basis. So
okay,
some of the transplant hospitals say that don't worry, we will take care of that. So
okay, nice thing then. Yeah.
Of that are ZTCC takes care. So it is definitely sorted out before the whole process of shifting is done, and also the family is kept in loop about it. That,
okay, ma'am. Thank you. And second question,
that brain death may not happen after shifting. The patient will be there, and that has happened in the past. So in that case, the recipient hospital has to wait till the cardiac arrest. The hospital, the transplant hospital where the donor is shifted. So they wait till then, and then the expenses.
Then only. Okay, ma'am. Thank you. And the second question is regarding MLC case. You said all the formalities will be completed by the police, and then the patient will be ready.
That is done by the transplant coordinator of the experienced hospital, madam, because
but sometimes
they cannot do it at their MLC. You just have to transfer the MLC.
Yeah, ma'am, we know that, but the thing is that many times they preserve the organs for further studies. For MLC cases, I am asking you, because they preserve liver, they preserve important organs, heart or lungs, like suppose they have to die.
Cases.
It was there.
Yeah, madam, this is organ donation for therapeutic purpose, and the law is very clear on it that we cannot use donated organs for research. So here we are talking about organ donation. The organs which can be used only will be retrieved, because a lot of cost is also involved in retrieval. So I'm mostly actually before the retrieval process starts, recipient is decided that whom the organ is going, and then So that's why the whole process of preservation of organ is not allowed as per the Human Organ Transplant Act here. So
Okay.
only you taking organs for therapeutic purposes, and we have to put it in the recipient's body mostly. And if any wastage, then that has to be reported, but those organs cannot be used for research purpose. We cannot just retrieve. A MLC case, madam, happens that many of our cases are medical legal cases because they are road traffic accident, head injuries, bike accidents. So they are the potential brain dead donors. So in that, before retrieving the organs, we have to intimate the police. That's a procedure as per the law of Human Organ Transplantation Act, that we have to inform them, and we have to take NOC from the forensic department that this is not going to affect declaring the cause of death. So these two certificates we need. So if they are convinced that, if I'm taking out lung, it is not going to affect the postmortem, they're okay with it. They just give that certificate and the body later on goes for postmortem. But before actually retrieving, we need these two NOCs from police and forensic. And that will be done by the transplant hospital. And that is after first apnea, rather after both the apnea. So the hospital which is shifting or not registered will not be involved in all this. But they just have to inform us that it's an MLC case. So it will help us in anticipating shifting while shifting.
So Dr. Dakore wanted to ask a question. You had raised hand. Dr. Dakore, do you want to ask a question? If you want to ask a question, please let me know. Okay. So yes, madam, you have elaborately explained the entire process, that once non-NTORC, we are talking from the point of view non-registered hospitals which are not registered for the retrieval process. So this entire webinar is probably meant for that, because the hospitals which are registered for the NTORC, they know how to go about with the process. For the doctors, for the hospitals, for the intensivists, for the emergency physicians probably who do not know, once you suspect that there is a potential brain dead patient, what to do next if you have identified a patient who may be brain dead, how to make use of that particular thing, and how to think in terms of organ donation. So this madam has given a very elaborate idea as to how would you go further, how would you take this procedure further to see to it that that patient gets converted into a potential organ donor. So thank you so much, madam, for this wonderfully elaborate session. And on behalf of IMA Maharashtra State Organ Donation Committee, we are extremely happy to present to you the certificate of appreciation for taking this excellent session on when and how to inform coordinating agencies during this program on Train the Saviors, organized by IMA Maharashtra State Organ Donation Committee in association with Roto Soto today on 23rd March 2022. So thank you so much, madam. And we move on now to our next session that, if you saw what Dr. Pandit was stressing upon, what Ashtekar madam was stressing upon, is something which is very, very delicate, and that is counseling of the relatives. How do you tell someone that your loved one may be brain dead and that person can become a potential organ donor, and that you need to start thinking in those terms? So this is something which is a very, very, very delicate, very, very emotional matter for the relatives. And so you need to have a very, very strong counseling techniques. You need to understand how would you talk to these relatives. So there are two aspects to counseling. One is when you think that the patient may be a potential brain dead donor at your hospital, which may not be a registered center for the retrieval, and probably at a retrieval center or at a transplant center where the patient is now to be undergoing a test, various tests to identify brainstem death, and then to declare that the patient probably is a brain dead patient, and the organs can be retrieved for the organ donation process. So for this we have Dr. Borade, who is, please allow me to introduce him. Dr. Prashant Borade, he is the director of Center for Critical Care at Global Hospital, Parel, Mumbai, with 22 years of experience. He has taken advanced training from UK. He has pioneered in setting up and running multi-organ transplant intensive care unit at Global Hospital, one of the busiest transplant centers in Mumbai, contributed to several research projects through intensive care societies across the world. So I now invite Dr. Prashant Borade to speak about counseling of relatives. Over to you, Dr. Borade.
Thank you, Dr. Pathak. Thank you for inviting me to speak on this topic today. So I'll just share my screen and then we'll start. Are you able to see my screen?
Yes.
Okay. Okay, so hello everyone. I'm Dr. Prashant Borade, Director of Critical Care Department at Global Hospital, Mumbai. And I'm going to talk on counseling of the donor families. So basically, as Dr. Vate was mentioning, counseling is a very important, step in the process of organ donation. And it's a tough job. Just imagine, you're going to declare someone brain dead, and you're going to counsel and you're going to ask them for donating their organs. Most of the time it happens that, the family members don't even know what is organ donation, and they don't even know what is brain death. So let alone the organ donation. So it's a tough task, and if done properly, I think the family will be satisfied, and then later on they will thank you for counseling them and pointing them or directing them towards organ donation, because the satisfaction once the grief is over of donating the organs and saving somebody's life is immense. And this issue they don't understand at the point when they're grieving, but later on they understand and they have immense satisfaction, and they will thank you all their lives if you direct them properly for donation of the organs of their loved ones who have become brain dead. So basically, you have to understand the process of organ donation. You have to have a lot of knowledge about organ donation before you start counseling. So let's have a look at that. What is organ donation? It's a practice of retrieving human organs from donor and transplanting into a recipient. Of course, everybody knows that. There are two types of donation, living and deceased. So living is your near or distant relatives or recipient, relatives of the recipient can donate their organs. So there is not much of hard work. Of course, you need to counsel the donor here as well, but the donation happens willingly. But the main challenge is the disease, donation after disease, brain death. So this is more often after the brain death. This donation after the cardiac death doesn't happen very much and not yet started to a greater extent in India, but abroad it is practiced. But donation after the brain death is happening, and Maharashtra is leading, thankfully, in last few years, where before that the state of Tamil Nadu was leading. Who's the recipient? Recipient is the patient who's suffering from irreversible organ failure and who will not survive unless he or she receives the organ transplant. And the whole process of transplantation is called retrieval. Which organs can be donated? Of course, everybody knows that: kidney, liver, heart, lung, pancreas, intestines also. So very important to know that. Being without the intestine, just want to make a point that being without the intestine is a very, very, very morbid life, very debilitating life to those who have lost their intestines because of several reasons. So what all tissues can be donated? Tissues, cornea, cartilages, bones, skin, heart valves, veins, muscles, tendons, ligaments, so lots. Yeah, and this is the important statement you need to remember. And during your process of counseling, you will have to say several times, And it is a truth. You're not lying to the family members. One single donor or your family member who has become brain dead can save 8 lives through the donation of their organs and save up to 100 lives through donation of the tissues. So remember this statement. That's why I made a separate slide on it. So remember the statement that you will have to use it several times during the conversation with the family, and they are going to ask you about how you're going to donate, what is going to happen after they give the consent, and several other questions. So very important, this slide. Okay, let's look at this clinical case. A 28-year-old gentleman, a biker, had a road traffic accident, hit by a truck on a highway. So he goes to the local hospital, and his vital parameters are like this. Heart rate is 124, blood pressure is 130/90, Glasgow Coma Scale is dropped to 10. So there is no doubt that there is some head injury involved, because your GCS has dropped to 10. And he was referred to tertiary care hospital, obviously, because he looks unwell and has got a major head injury, looks like. So on arrival in the super specialty hospital or a tertiary care center, his GCS further deteriorates to 3/15. And the CT scan reveals that he's got subdural hematoma, subarachnoid hemorrhage, and cerebral contusion. And he undergoes urgent neurosurgical intervention. Day 3, despite all possible medical and surgical treatment, no neurological response. Now, what do? You have to explain to the family. How do you approach the family? So before going to the family to discuss about the patient's clinical state, you need to understand a lot of things. First of all, you need to understand really, is this where are we going with this patient, right? Is he brain dead? Does he need any other surgical intervention? Is there any medical etiology behind this Glasgow Coma Scale of 3? What exactly are you going to tell the family, right? So apart from understanding the clinical issues, you need to understand the process of the organ donation. So of course, the process involves these steps. Number 1 is the diagnosis. Of course, here it is very straightforward. As Mr. Sujata was telling earlier, that most of the brain dead patients are coming with a head injury after a road traffic accident, which is the case in our possibly a case in our patient as well. So first you have to diagnose what exactly is the problem, clinical diagnosis. Then a referral center, which the local hospital very well did, to the tertiary care center. And then you're at the step where we are going to discuss with the family. And then after the discussion with the family, you go ahead and do the medical evaluation, as opposed to, is there any other reason for his Glasgow Coma Scale being 3, or is he brain dead, or all his organs are doing well? And then once the family discuss and decides about organ donation, then comes the process of matching, surgical recovery, preservation of organs, and then transplantation. So this process you need to know, because they will ask you, the families and the family members or the relatives will ask you lots of questions, and you need to know the process apart from the clinical details very well. So again, another issue is in the process is the steps of process in organ donation, right? So first of all, you're identifying the donor, evaluating whether the donor's eligibility is there or not, because again, that question will arise, from educated family, whether his organs whether he's eligible to donate the organs. And suppose if the patient is suffering from previous cancer and he's not eligible to donate, and you go and counsel the family, such a family, I mean, you're making fool of yourself. Like later on, once they give the consent, later on you'll go and say that, oh no, he suffered from a cancer in the past, so he can't donate his organs. So understand the patient first, understand the clinical scenario, understand the patient's background, understand whether he's eligible or fit to donate, and then approach. While you're doing the counseling of the family, it is very important to maintain the patient medically. Once the family gives the consent for organ donation, make sure your coordinator or the organ transplant coordinator is involved, and then he coordinates with several authorities, state and regional and national transplant authorities in following the process very smoothly. So apart from traumatic brain injury or after the accident, these are the other reasons where the patients can become brain dead. So cerebral vascular accidents, stroke, intracranial bleed, subarachnoid hemorrhage, subdural hemorrhage, intracranial space occupying lesion. So intracranial space occupying lesion means there might be some tumor, but not all tumors you can donate. It is important to know which are malignant tumors and which are not. So there are some tumors of the tumors of the brain, especially, where you can go ahead and donate the organs, and that's not a contraindication not to donate. So it is very important to know that. So that's why I put space occupying lesion. Brainstem death involves coma, absent brainstem reflexes, and apnea. So this is the criteria which you need to understand before diagnosing brainstem. If the patient is comatose, I mean, there could be hundreds of reasons of coma, but all coma doesn't mean that your patient is brainstem death. You need to have all three of them. So you need to have coma, you need to have absent brainstem reflexes. So you evaluate all the cranial nerves right from 1 to 12 and see whether the patient is apneic by doing apnea test. So it is very important to understand the diagnosis of the patient, as I said. I can't stress enough on this. And then understand that the patient is brain dead before you go ahead and counsel the family member. Again, the same issue of eligibility, age should be less than 80 years, but nowadays, even more than 85 years or 90 years also, we have transplanted liver. Maybe the other organs may not be good enough, but age doesn't look like anymore a criteria for some organs, although best is age 80, the organs do very well. Cancer and malignancy ruled out from the eligibility, viral infections ruled out, all routine investigations to check organ functionality. Now, remember, bacterial infections are not really a contraindication to donate, but viral infections may be, depending on which viral infection you're suffering. Right now, steps to approach the family for authorization of organ recovery. Okay, so first of all, obviously, you're going to break the bad news of the family members being brain dead. Then explain the condition in detail about what is brainstem death, because as I said, many of them don't know what is brainstem death. Allow the time for grief. Patients the family members don't understand what is brainstem death, so they don't really accept, because it is as good as saying that your family member is dead and nothing can be done beyond that. But when they go and see, the ECG, the cardiac monitor is showing the heartbeats, the patient is breathing, the oxygen saturation is there, the patient is warm to touch, and so on, and they won't believe you, the family won't believe you. And it is very important to make them understand, and that's the trick, and that's your skills of explaining about brainstem death and breaking the bad news. And this immediately should be followed by counseling for organ donation. There is no consensus on whether both things can be done at one sitting, or you should meet the family separately. It also depends on how the acceptance of the family members is to your bad news. So when you break the bad news, you just see how the family is accepting the news, and depending on that, you understand whether you need to go to the next step of counseling for organ donation or not. If the family is just not accepting and they are in severe grief, which we'll talk about, I don't think it is appropriate time to broach the topic of organ donation at all. So it is very important to time the steps of breaking the bad news and counseling for organ donations. Very important. And of course, once the family consents for organ donation, then next steps of getting the coordinator involved and informing the appropriate authorities, the transplant coordination authorities, is very important. So coming back to our case, this 28-year gentleman biker who had a road traffic accident, dropped the Glasgow Coma Scale to 3, and then, after all possible medical and neurosurgical treatment, he didn't really improve. So you've got to do two things. One is break the bad news and then counsel for organ donation. How do you approach? So there are a few steps you need to really understand about approach to the patient's family members. So first and the foremost thing is prepare yourself. So don't go without preparing yourself. Just imagine you don't know much about the patient. You don't know much about who's the family member, and you go and talk to the family members. That's not going to help at all. I mean, the family will not develop a rapport with you, and they will start hating you. They will get the anger on you and of the situation. And they will just go against you, and it will be incredibly difficult to get them to donate the organs. So it is very important you understand who needs to be there from the family. So if there is only 1 or 2 people from the family, whether they need the support for rest of the family members, so you understand who all need to be there. That's the first thing you need to know. And, get everybody together. Otherwise, what might happen is you might explain 1 or 2 family members, and they might not be the decision maker, but XYZ may be the decision maker, and you might have to go with the whole process all over again, wasting your time. So that's why it is very important to know who needs to be there from the family, and whether the family support, extended family support need to be there, or the decision makers from the family are there to break the bad news, and of course to discuss about organ donation. Then plan your meeting. So how do you plan? Understand who are you going to meet. Know their correct names. It might not be that you know everything, but at least when you meet them, introduce yourself, and then ask them to introduce one by one, and remember the names of the people who are sitting across the table, so that you can during the discussion, you can really take their names, and they will be impressed that the doctor really remember my name, even if there are 5 or 7 of them. Right? Understand what are you going to talk. So content of your message is very important. Know the details well. Like I said, know the details of the process of the organ donation very well. Know the patient's clinical details very well. Without that, if they ask you some question and you are not able to answer, of course you mustn't lie at all. But if you're not able to answer the clinical details, then it's not going to create a good impression of you, and you won't be able to build up a good rapport again. What do I want to get across and how? So of course, your aim is to break the bad news, make them understand about the brainstem death, and once they accept, again, whether they accept or not, that depends on how you counsel the family members. So once they accept, then discuss about organ donation. Now, understanding and gathering this information, you need to talk to the staff members. If that sometimes the nurses, most of the time the nurses know about the family members better than us, because we may round the patient once, twice in a day, but the nursing staff is always there with the patients and their family, and they have more rapport with their family members. So talk to the nursing staff or any other paramedical staff and understand if they know more about the patient and the patient's family, and try to gather more information from them. Seek advice if required from the nursing staff. So sometimes, it is helpful for me, if I ask the nursing staff, they might say, no, this family member is very difficult. You might have to approach this family member with a little bit of care. So you're well prepared. So, you know the person's name, what is he doing, what is his query, what are his issues, what are his concerns, and all that. Once you have all this information, it's very easy to talk to them. In the preparation phase, very important to understand where are you going to, discuss with the family, to whom you are going to talk, and when. So it is also important when are you going to talk to the family. It should not be like, you diagnose the patient to be brain dead at middle of the night at 1 o'clock, and now you want to discuss with the family right now. You want to break the bad news right now. So understand, is it the appropriate time? Are all the family members going to be available there? Is the patient so clinically unstable that you cannot wait till the morning when all the family members are there, the decision makers? So understand when, not only where and to whom, but to very important is when, right? Definitely not to counsel in the middle of the night. Location, where are you going to counsel? Very important. You have the location, the room has to be private, it has to be comfortable, appropriate layout has to be there. There shouldn't be no disturbance, like, your phone is going on in every 5 minutes while you're talking to the family. That doesn't really create a very good impression. And also the concentration or the link of what you're talking get disturbed, and you may have to repeat the same thing again to the family members, and it is extremely annoying. At least that's my personal opinion. But I think that's the right way to approach the family. Keep your phones on silent. Set aside sufficient time. So counseling is not going to happen in 5 to 10 minutes. You should give at least half an hour of your time if you want to break the bad news and counsel the family for the organ donation. It's not going to happen in 5 to 10 minutes, definitely, for sure. So set aside sufficient of your time. If you're in a hurry, that's not the right time to talk to the family. Again, as I said, support people. So, if the family members are two young son and a daughter, says, for example, 18 years and 12 years, these youngsters are not going to understand. You may have some elderly person from the family to support them if you want to break the bad news. And similarly, I'm just giving an example. It's not a stereotype, but I'm just giving example of young family members, and then you may have elderly. For that matter, even the elderly don't understand, and then you may have young ones to try and make them understand. So understand if the support. The most important thing, or the main point of discussion, is the communication skill. So you understood about preparation, you understood about location, and now how are you going to communicate? So this is the most important part of counseling the family. And this involves 4 steps. So active listening, emotional reaction, nonverbal communication, and language and informations, right? So let's talk about active listening. So your goal of listening is listen for the meaning, okay, to try and understand each other mutually. That is why you're going to listen. It's not that only you are going to talk. I think you listen more than you talk. The lesser the information you give, the more concise the information you give, and then listen to the questions and understand what is their concern. That is going to help, rather than you just talking and not allowing them, the family members, to talk and not listening appropriately to them. Assess the signs of comprehension. So you talk to them and ask them to repeat if they understand, whether they are paying attention to you, whether they are in a grief, whether it is a right time to talk to them about the next step. Or is it just you give a break, you just explain the bad news and just give them a break and wait for the next steps. So listening techniques are repetition, facilitation, reflection, empathy, and summarizing the details which you are given, or ask them to summarize the details which you are given. Right. So these are the steps of listening which you need to follow. Repetition is basically, if they have any concerns, and if they voice the concerns, or if they are, for example, just say that the deceased patient, or the patient who's brain dead, his name is Ram. So the family members tells you, you explain to the family member, and the family member is in a grief, and he or she just mentions, say suppose Ram's father mentions to you, Ram was a very good basketball player, right? So you repeat and say, I'm sure he was. and just nod and then just give a pause. So facilitate the discussion. If they are unable to complete the sentence, facilitate the discussion. So these are the different ways you need to repeat, facilitate, reflect what they are saying, empathize with them, and ultimately summarize about the character which the family members is giving you about the brain dead patient. So simple things like that. Emotional reaction. So understand the emotional reactions. It is very important to understand the family members, because they will be going through this cycle of grief, which is called Kubler-Ross's grief cycle. So initially there is denial. So once you break the bad news, they will not accept that their loved one is brain dead, and they're literally dead basically. Then they will have a phase of anger. Why did it happen? How did it happen? Why did he go on the bike? Why did he not wear the helmet? It's the anger, it's the anger of the situation. The anger is not towards you. So understand that anger. Then they will start negotiating with you, bargaining kind of. No, sir, please do something. Call this neurosurgeon, call that neurosurgeon. Just try this medicine, just try that medicine. I will call this doctor, I will call that doctor. Just agree to what they say, and just keep your stance that he's brain dead, and these are the reasons why he's brain dead. So they will negotiate, but you need to understand the phase of the emotional reaction they are undergoing. Depression, they will go in depression, and then they will accept gradually. Now, the time for finishing this cycle is variable in various different types of family, depending on what is their relationship or how emotionally connected they are to their loved ones. So you need to understand all these phases of emotional reaction. Again, I'm just going to finish in 2 minutes, right? Non-verbal communication. So these are the important non-verbal communications you need to look into, right? Your body language, your posture, your eye contact when you're talking with the family, how much you're blinking, what is the tone of your voice, your facial expression, the gestures. So all this you need to pay attention while talking to the family members, because this is all important. So it feels like your whole body is empathizing with the family member. You literally have to feel their loved ones, feel their grief that their loved ones have died and they're no more. So all these non-verbal communications are very important. As I said, listening and non-verbal communication works better than, a lot of talking to be done. And the last important thing is language information. Use very simple language, avoid medical jargons, use native language when possible. If you know Punjabi or Gujarati or Marathi, and you can, if the family member is from that native language, and if you can speak, nothing like it, very good. Avoid information overload. So, just talking too much is not really good, because the family members won't understand what information to take. So deliver information in small bits, tailor your information so that the family understands it very well. Monitor the pace of information, don't go too fast or too slow, and allow the time for reflection for the family so that they have understand and close the loop of the communication once they repeat what you want to say. And ending the discussion is also very important. Answer all their questions, offer the support they need, arrange a follow-up meeting with them, because sometimes they might not understand the whole thing and it might consume too much of your time. So give 15 to 20 minutes, maximum half an hour for a meeting. And then if you're still not able to put across your point to the family, or the family members have not understood your point, arrange for another meeting or a follow-up meeting. Again, the same thing, because you're going to discuss two topics, breaking the bad news and discussing about organ donation. So maybe not possible in one meeting, arrange another follow-up meeting after a couple of hours of break, or maybe next day. And documentation is most important, as we say. And of course, we all know the myths, and you really need to address these myths of the family member, because 100%, one of the myths will be one of the questions of the family members. So my body will be disfigured after donation. Doctors will not look after me if I agree to donate. Age only above 18 can donate. At my age, organs will not be useful for the younger person. And there are several other myths. So address all these myths. So when you in your preparation phase, prepare all this, how you're going to address the myths. And then in the end, of course, as I discussed, the steps of the steps in the process of organ and tissue donation, you need to know all the steps, but most important is the follow-up with the family and the support which you need to offer to the family members. Right. So organ donation is a noble cause. Again, one person saves 8 lives. Gain more knowledge about organ donation and spread awareness. Clear the misunderstanding and myths. And again, as I always say, remember, if the millions decide to donate in the second largest populated country in the world, many lives can be saved, including our loved ones, if they are in a need eventually. Thank you.
That was really wonderful, Dr. Borade, and you have made it amply clear that it needs to be a two-way, empathic, human, but professional and scientifically accurate communication with the relatives when you are talking about a subject as delicate as organ donation with a patient who's likely to be a young patient, because we are talking more or so about, road traffic accidents or so, or whatever age the patient may be. But finally, we are talking in terms of death, and the relatives are always talking and thinking in terms of life. So we need to make it very well understood. And it is my personal feeling that there are two things where we fail. Majority of us are good clinicians, but where our medical profession fails is, one is communication and second is documentation. So these are the two things where our medical professionals fail to a very, very large extent. And communication skills is one of the major aspects of any situation that you deal with in your clinical scenario. And please, just a word of caution from my end that in today's materialistic and changing world, talk of death may give rise to emotions which are extremely angry and violent. So please assess the relatives before you put forward any talk about brain death or possible brain death or possible organ donation, because these may bring forward some episodes of violence against the medical professionals if not done correctly. So please beware of how and what you talk. With this, we put this session, we can take a few questions if there are any. So if there are any questions, please, you may either ask in the chat box or you may raise your hand and I'll invite you to ask your question. So Dr. Borade, till someone asked a question, my question to you is that in the second last slide, you said that you need to document what you have spoken. So now when we speak about documentation, we generally tell, the doctors that you need to document everything in detail. If you're doing a surgical procedure, then you're supposed to explain it in the language that they understand, with the pros and cons explained and the possible complications explained. So everything has to be put technically, elaborately into the documentation. So here, when you counsel the relatives regarding a possible brain death, so are you expecting the relatives to do, rather the doctor to do a complete technical documentation as to what all things have been spoken and what are the reasons why you're talking about these things?
Yes, I think I would agree with that. You document as elaborate as possible. So ideally, what we do is the best is to do the interview in a audiovisual location with an audiovisual facility, so that everything gets recorded. That's the ideal way to do it. But even if you don't have that facility, you document and you keep one of your staff members with you. So it has been my practice always, all along, which I have learned abroad as well, that while communicating to the family, I keep a chaperone, kind of, so I keep a nursing staff who's looking after that patient. So the nursing staff helps me, facilitates me to communicate with the family. And of course, vice versa also, because the nursing staff has developed some sort of rapport with the family. So that is one. And then when you document, I would document the important points, like, you discussed on a point of breaking bad news, wherein you have spoken. So suppose if I'm breaking bad news, right, in this patient which I spoke about, so I'm going to talk about the diagnosis, right? How did we diagnose? What did we diagnose? How did we diagnose? So the diagnosis is through the CT scan, which we did. Then what did we do about it, right? So what treatment did we do? So we did the neurosurgical treatment. Then we did what medical treatment did we do? So these are so I'm not going to document every single detail, but this is what I spoke about on this topic: diagnosis, medical treatment, surgical treatment. And then what was the outcome, right? And then when you explain to the family, explain about, say you're explaining about brainstem death. So what have you explained about brainstem death? You remember the 3 points which I said. One was apnea, one was absent brainstem reflexes, and coma. So these are the important points which will protect you medico-legally, right? So if you document everything and you miss out on the patient was comatose or absent brainstem reflexes and apnea, then I don't know whether you documented it properly.
No,
you see what I mean?
My question was rather different, that we are not talking from the transplant center point of view. We are talking from the point of view of a non-NTORC, where they cannot still declare a patient brain death. All they can probably say that there is a possibility of brain death, because the non-NTORC do not have any, this to declare the patient as brain dead till then. So in that, what are the documentation, or rather till what extent are they supposed to talk to the relatives? And with that, what documentation are they supposed to do? I mean, do they say that we have explained the possibility of brain death, and do they take the signature of the relatives on that? I mean,
no. So see, for such a center where they cannot do the brainstem death test, or say suppose facility is not there to do the brainstem death test, you of course explain your clinical suspicion, right? So obviously you're going to understand, means so apnea test is a formal test, but when you do your daily clinical examination, you are going to understand whether this patient is brainstem or not. So if the doctor identifies that absent cranial nerve reflexes, and based on that you are saying that there is a possibility of brainstem death, and leave it at that, and then of course they have to make the family understand what is the next step, because the family is going to ask that. So this is what I'm saying. The best thing is to document about the clinical scenario, about what is your current diagnosis and what are you going to do about it, and what is the next step. So these are the basic things you need to document. I mean, I wouldn't say fill pages and pages about documentation, but the relevant points, it has to come across.
Right. So clinical summary should be there, which is at least covering all the major points. So I invite Dr. Manyar Ajaz wants to ask a question. Dr. Ajaz, please unmute yourself and ask a question.
Thank you, ma'am. I'm sorry, I unfortunately lost first lecture. I just wanted to know what protocol is there for inotropes to be used in brain dead patient. Is it optimum most level?
If I may answer that, that was not the topic of discussion, but there is a whole protocol for maintenance of the brain dead patients, right? Now, certain things you need to avoid, and certain things. Now, it depends on how your patient is. So, for example, if I may say, if a patient is again, at what phase of the brainstem death the patient is. So right in the beginning, when the patient becomes brain dead, in first initial few minutes to an hour, the hemodynamics may vary so widely that you would have extreme difficulty in either maintaining the blood pressure in a normal range when the patient goes hypotensive, or the other way around, hypotensive. If the patient starts going, there is a sympathetic surge, in the initial phase, and the patient becomes very hypertensive. And if you give some labetalol or NTG, the next thing you will realize that the blood pressure will go very low, and it's incredibly difficult to get the blood pressure up. So these things need to be really gently treated. And once the patient is stabilized in this first phase, then you really need to understand whether your patient needs vasopressin or noradrenaline or adrenaline. That depends on which organ is affected. So say, suppose if the patient also has a cardiac failure and he has become brain dead, and he's like a 68-year-old gentleman who is known to have cardiomyopathy, and he's had a fall and he has a brain dead. Are you going to give vasopressin? Maybe not. You may want to give adrenaline, right? Because of course you're not going to use this heart for transplant, but you're going to use other organs. Similarly, if the patient is liver failure, chronic liver failure, but the kidneys, lungs, and the heart is working very well, you might want to prefer vasopressin, or it depends on the clinical scenario. But I would not use anything more than vasopressin, because it takes care of your antidiuretic hormone as well, because your pituitary is gone and so on. So it's a whole new discussion, in detail. I mean, next time, we can arrange that as a topic, and we can discuss in detail on this.
Yes.
So one more question, if I am permitted.
If you can just put it in the chat box, because now we are running behind schedule. So if you can just put it in the chat box, and Dr. Borade, if you would be kind enough to address the question in the chat box.
Sure, will do.
Yes,
Okay,
thank you
ma'am,
so
thank
much.
you.
Yeah. So thank you so much, Dr. Borade. And I think the communication part has been covered very well by you, and you have made it amply clear that it is a sensitive topic and it needs to be handled equally sensitively. And rather, I would say one of the most important aspects where you really talk to the relatives of somebody who is expected to be announced as, technically probably dead. So you covered it really, really well. And thank you so much for that. And on behalf of IMA Maharashtra State Organ Donation Committee, please give me a minute. I'll share my screen. We present the certificate of appreciation to you for taking this session on counseling of relatives during organ donation awareness program of Train the Saviors on 23rd of March 2022. Thank you so much. Thank you. So with this, we move to the end of our program and towards the last session for today. And nevertheless, we can say that it is one of the most important aspects of organ donation, that you cannot give or take organ donations as you may please. There's a whole sort of a law which is in place. There is an entire organization. Rather, there are complexity of organizations which are at play. How the organs are retrieved, how the organs are listed, how the organs are distributed, and what are the laws associated with it. So to explain this, we have none other than the director of Roto Soto, Dr. Sujata Patwardhan Madam, to talk about the functioning of Roto Soto Noto and what are the laws associated with transplantation. So it is my pleasure to introduce Madam. Please give me a second to share my screen. So Dr. Sujata Patwardhan Madam, she's director in charge, Roto Soto, Mumbai. She's professor and head Department of Urology at GS Medical College and KM Hospital, Parel, Mumbai. She's recognized teacher for Mumbai University and MUHS Nashik for MCH Urology since May 2001. She's recognized transplant surgeon with DHS Mumbai. She's examiner for MCH University of Rajasthan. She's scientific advisor and expert to ICMR research studies. She's examiner for MCH at University of Mumbai. She's examiner for Mumbai Institute of Health Sciences, and she's examiner for Gujarat University. A warm welcome to you on this platform, ma'am, and we hand over the session to you. Madam, at the bottom, if you want to just make it full screen, go at the bottom. Please, yeah, just move left, still left, slightly left. The next icon, ma'am, the next icon. Yeah. Madam, you're not audible. Are you speaking? Madam, you're not audible.
Yeah. Hello.
Yes,
Can
madam.
you hear me?
Yes,
Actually,
yes.
the host was not allowing me, myself to be muted,
You are
and that's
co-host,
why I
madam.
sent you a message also.
No, you are co-host,
Yeah,
madam.
but it was not allowing me to
Okay,
unmute. Now
okay,
it has got
okay.
unmuted.
Sure, ma'am.
Anyway, thank you. It's nice to be with you here, and I hope you can hear me clear.
Yes, yes, madam. Absolutely.
Yeah, I'm thankful for IMA Maharashtra and organ donation branch to take up this so very actively. And there are 115 participants. I'm really overwhelmed that all of you are listening with so much of great interest. And I really didn't know that people are so interested in this topic. So I'm supposed to cover the law and also tell you about what Roto Soto we do at Roto Soto Mumbai. The Roto means the Regional Organ Transplant and Tissue Organization, and Soto is state is similar for the state. So it is very difficult for me to complete the law in such a short time, but I will go over the salient features of the law. And as everybody of us know that it was passed in 1994, but that was having a lot of loopholes and all, and it has been amended on various occasions in 2014, in 2009 again, and then in 2014 and in 2017, and many have been made, many have been added. So basically, what does the law say? The law says that it accepts brainstem death as a mode of death. Previously, we used to only consider cardiorespiratory death, and we used to write in our, even I have written as a resident that it is the cardiac and the respiratory systems have ceased to function, and hence the patient is dead. So now the concept of brainstem death was accepted in the law. That was the first main thing. And it has been given clinical recognition. So if you certify a person as brainstem death, it will be legally acceptable and there will be no issues about it. This is one major thing which everybody of us need to know and need to not be afraid of, that brainstem death is the legal form of death and it is accepted. Though there are some loopholes to it, and we need to have a few more amendments to it as to how it can be. But these are little fine nuances, and I won't go into it. Then what else has the law said? The law says that organs can be taken from the patients who are brainstem death, and they can be utilized only for transplantation. They cannot be utilized for research. So this is one major understanding which we need to have, that if we take consent for organ donation, we have to see that the organs are utilized for transplantation. And we cannot just take the organs and put them in the dustbin, or we cannot send them to any lab for research, or we cannot do any animal studies with it. This is the very second important thing. Thirdly, the law wants to curb the commerce in organ donation. So there should be no give and take of money for organs. And there are various rules and various regulations by which this can be achieved. So how does the law achieve this? The law achieves this by making people, only certain people in charge of the process. So organ transplantation can occur only in a recognized hospital. Organ transplantation can be done only by a transplant surgeon, provided he is registered with the government. Same for the transplant physician, same for the transplant anesthetist. So the hospital has to be recognized, the surgeon has to be recognized, the physician has to be recognized, then the anesthetist has to be recognized, the brainstem death committee has to be recognized. So nobody in this whole process can do the process of organ donation without having their name registered with DHS. Then there is a separate section where all the rules and regulations are given about how a how can a hospital be eligible to be recognized as a transplant hospital, or how can a surgeon be eligible to be recognized as a transplant surgeon. For example, for kidney, you have to complete at least 25 kidney transplants, which you have assisted. So similarly for liver and heart and other tissues. So I'm just giving you an example, like if we have the organ transplant recognition in KEM hospital for kidney, liver, and plastic surgery has it for hand. Now, day before yesterday, the orthopedic surgeons said that we want to harvest a composite graft involving the tibia and some tendons there and a part of the cartilage of the knee joint or whatever. So, but when I asked DHS, they said no, because they have not registered themselves as tissue transplant surgeons. So even though we have the permission for tissues and hand with the plastic surgery department, the orthopedic surgery has to apply separately. Now, we want to start in KM simultaneous kidney pancreas transplant. I am only recognized as a kidney transplant surgeon. So now I have to reapply to be appointed as a simultaneous kidney pancreas transplant surgeon. So I'm just giving you examples so that you understand that the law sees to it that you are registered with the government, you have specific conditions. And can you just excuse me for just a half a minute? The dean is calling, just half a minute. Hello? Hello?
Yes, madam. Yes, madam.
Yeah, I'm extremely
Yeah.
sorry. It was
No.
regarding some union problem in our department. Anyway, so then I told you like how the government is strict about this thing. Then the next chapter is about who can be a living donor. Like what are the criteria for being a living donor? Who can become? What is the definition of next of kin? What is the extended family? Then also the criteria for swap. So each and everything is defined, but there are definitely lots of loopholes which we have to fill up. And I'm also a part of, along with Sujata and Akash, and we are a part of the state advisory committee where we will be advising the government as to what reformations we want in the law. And these things are ongoing. Now, in view, the next point which I wanted to cover is the law has very specific rules about a woman being a donor, because they do not want women to be exploited by men and by other women to become a donor, as we know that women are being exploited and they were exploited. So a special note is there about women donors, like if a woman volunteers to donate her kidney or liver to her relative, then what should be the procedure? Then somebody from her family should be involved. They should be asked separately. She should be counseled properly. So all these things are written very carefully in the law. There is also a lot of formalities and lot of paperwork involved in organ donation. As I told you, once we get the consent, we have to record the consent in a specific format. There are forms for it, and there are forms for police NOC, there are forms for forensic. I'm not in the law, I'm not going to use any slides, madam, but for Roto Soto functioning, I'll be using my slides. For the law, I'm just giving you an overview of the law, and any specific questions from you, I will answer, because it is not possible to complete about 150 pages in 15 minutes. So kindly excuse me, I did not prepare the slides for the law. Though we have this presentation and we have all the law written on our Roto Soto website. Anybody who would like to go there, they will get the copies of the law from there. They can download it. And so I was telling you about the women donors. So I was telling you about the forms. So there are hundreds of forms which are there form for hospital recognition, form for re-recognition. Then, as I told you, consent about organ donation. Then this NOC, that NOC. Then finally the letters which we have to write to each other, inter-hospital, of when we get an organ from some other hospital. So in general, there is one section of the law where all these forms about living donation are given. There are about 4 to 5 affidavits which have to be done, a set of documents which have to be certified. And we are not concerned in this program about live donation, but I'll just try and explain in 1 or 2 sentences that if a person wants to donate any organ when they're living, and the hospital is doing less than 25 number of transplants, then their permission is given by the committee which is at the state. But now there are committees at Pune, Aurangabad also. Previously, there was only one committee at Mumbai. And if the hospital is doing more than 25 number of transplants in a year, then the hospital CEO or hospital's dean is themselves given the permission. They can check the papers and give the permission for organ donation. However, there are a separate set of rules for foreign nationals, separate set of rules if an emotionally related person wants to donate, like a friend, or there are altruistic donations. So all for this, there are different rules. So I will stop my talk about the law because it is really a very huge topic, but I will be ready to answer any specific questions you have. Okay, so Sujata, can we, yeah, I can see Mr. Vijay Shivpuje raising his hand. Madam, would you like to take his
Madam, we'll take
question
question
right now
towards
or
the
at the
end.
end?
We'll take it towards the end altogether.
Yeah, sure. Yeah. So now in 2014, the government realized that organ donation is happening very haphazardly in different states, and different states have different protocols of how they want to allocate organs and distribute organs, and there is no uniformity. So they formed a national level organization, regional level, and one state level human organ and tissue uh, uh, organization in each and every state. However, not all the states in India have adopted to it, and there are not about 25 states who have adopted it. Then they perform 4 to 5 states together were taken care by a regional center, so that any problems or any organ allocation within the region can be done by that regional organization. Why is this done? Because transport of organs, suppose there is an organ which is excess in Chennai and we want to transport it to Delhi or to Kashmir. The time involved, the flight involved, the cost involved is very high. So it is better for Chennai to share with Kerala or with Karnataka, being neighboring states. So similarly, there are regional 5 regions in India, out of which we are the head of one region, and this region involves Maharashtra, Gujarat, Goa, Diu Daman, Chhattisgarh, and Dadra Nagar Haveli. And all, we are supervising the programs in this region. So here, this next slide is showing you that St. GS Medical College is responsible for these states. And similarly, there are other centers which are identified by the central government, and they are made in charge of the other states. Now, what is the function as a regional organization? That we have to monitor and surveillance the transplant activities of our region. We have to collect the statistics from each state in our region, and we have to maintain a data bank. We have to maintain the follow-up and the organ donor registry of our region. Then the government has various schemes for organ transplant. NOTP is one major program of the government, under which they give money for various activities, like there is money for below poverty line patients for immunosuppression to be given every month. Then there is money for which Sujata Ashtekar was mentioning, that if there is an NTORC and it does an organ donation and doesn't utilize any organs, then 50,000 has to be given. And there are multiple good things in this scheme, but the issue with it is the flow of money is not regular. In fact, this is the first time after 2017 that we are receiving money under this scheme for patients who are in below poverty line for their immunosuppression support. So yeah, but we can't totally disregard the government for this. The thinking is at least appropriate, and though not in time, they are able to implement these programs, though a bit slowly. Then what do? We have to do IEC. IEC, that is, we have to organize and conduct training programs. So our next training program is in Kolhapur. It is from the 4th of April for the next 5 days, and it is a certificate course which is certified, and you will get the certificate directly from the government of India. So we hold courses like this in our region, that is Maharashtra, and we also go to other states. Like we are planning to go to Surat. Our ICU training course will be in Nasik in the next few months. Last year we had it in Gujarat and in Raipur and in Pune. So this time it will be in Kolhapur, Mumbai, Nasik, and Surat. So these things are there on our website, and please do take care of, utilize these opportunities. Then creating awareness, I'll just come to that in the last few slides, how we are creating awareness about organ donation. Then we do advocacy workshops in the region. Then of course, we provide technical guidance. Now, how do we provide technical guidance? We have various committees. We have committees right from liver, heart, lung, pancreas, bowel, hand, face, and even uterus, and we have tissue also. Plus, we have an academic committee. We have a forensic committee. We have hundreds of committees, and whatever problem comes, the committee addresses the problem. Next slide, please. Now, as I told you, KEM Hospital also functions as the SOTO for Maharashtra. And here we have a common waiting list. As Sujata must have explained, that we have 4 ZTCCs in Maharashtra: Mumbai, Pune, Aurangabad, Nagpur. And we are in the process of having a common waiting list of all the patients who are waiting for kidney and all the organs with us. Then we facilitate multi-organ retrieval from the donors, and we have a retrieval OT now in KEM Hospital, which will be mainly using for donors from KEM or any other place, like if they need to be transferred from an NTORC. Then we do a collection of data, and we send it every month to NOTO. Then we give information to various hospitals, and we follow up patients of the transplant and see what they are doing. And we take an audit if there is a death of a donor or death of a recipient. That also is being done. And we are now collecting data about the donors. So forget the recipients, the donors are also very important part of this whole live donation scheme, and they cannot be neglected. So we are trying to get this data also from our transplant hospitals. Next slide, please. So how do we function? Now, this slide is a bit old. Now, Dr. Sangeeta Rawat is the president. I'm the director in charge, Dr. Arun from DHS. Dr. Akash Shukla is the GI medicine person. Vinita Puri is plastic surgeon. Tukaram is the nephrologist. Prabhu is a GI surgeon. And Kamakshi Bhatte, though she is an ex-KMite, she is in charge of our IAC material. So all the transplant surgeons in our hospital, we form an advisory committee, but this is only for our day-to-day functioning of the ROTO office and certain permissions and certain decisions which we have to take. Next slide, please. So this is our structure of our office, that is director, joint director, consultants, MSWs, and program assistants. Next slide. So this is only a view of our office, and it has one conference room where we can seat about 12 to 15 people very easily. And Sujata has her office, and there is a director office, and there is a working station for the clerical staff. Next slide. Then, as I told you, we have, how do we work is which we have lots of committees, and critical care committee, there are subcommittee for each organ, tissue and composite tissue, forensic research, publication, donor audit, and awareness activity committees. Next slide, please. Activities are IEC, will come and tell you in the next slides, and we do training and we do allocation. Now, we don't do allocation within Mumbai or within Pune. We do allocation between Mumbai, Pune, Nagpur, Aurangabad, or any other transplant hospitals within the state. So we are, suppose there is an excess organ in Pune and they want to share it with somebody, then we find out that who is the appropriate recipient for it and how to go ahead. Is the donor in a proper properly fit donor and what are his parameters, is COVID done, and have thousands of things. So we do it mainly through WhatsApp, and this process goes on day in and day out. And then we offer the organ in Maharashtra. If there are no takers in Maharashtra, we offer it to Goa, Chhattisgarh, Gujarat. And suppose there are no takers there also, then we have to offer it to Noto. So the coordination or allocation of organs within Maharashtra, within our region, and within our region and the rest of India is done by us. We have formed all the new guidelines because guidelines were formed in 2001. And for the last 20 years, they were not revised. So we had to spend almost 2 years and get all committees and get all the recent advances, and each organ guidelines have been formed and they have been accepted by Government of Maharashtra. There has been a new app which is implementing these guidelines, and now everything will become digital and it should go on floor in the next 15 to 20 days. Next slide. So as I told you that we conduct training workshops. These are old photographs. Next slide. Yeah, this was with the previous director, Noto, and this is where we felicitate the donor families. Next slide. Slide. So we pre-COVID times, we did have training workshops, awareness activities. Next slide. Can you go to the next slide? Yeah, next. Next, please. So we do this activities for police personnel, for ICU intensivist. We have to plan one for forensic doctors, and plus Sujata and her team, they go to the nurses college and they take lectures for the nurses. Also, awareness activities are taken for MBBS students and for the administrative staff. Then we hold small competitions, Rangoli competitions, and poster competitions. Next slide. Next slide, please. So we recently inaugurated a monument for the small temple-like thing where we made it for the organ donors. And then we had a cadaver retrieval workshop at Goa, and we taught the surgeons there retrieval techniques. Next slide. So I need to tell you about the training center because this is our latest thing. We are inaugurating mostly on 16th of April. We have our first retrieval workshop on 17th of April, where we'll be training 8 doctors of each organ, that is kidney 8, heart 8, liver 8, bowel 8, hand 8. So like all these doctors will be invited. Initially, as it is our first program, we are taking people only from Mumbai. And the faculty also will be from Mumbai, and we will have an online course where we'll share the material and videos, and then we'll give them actual hands-on training on an actual cadaver. So this will be done. And next slide, please. This will be also available. This cadaver lab and retrieval OT facilities will be available for bone and tissue, that is skin donation, if it is happening anywhere in the city of Mumbai. They are free to contact us, and we will arrange the OT and the necessary arrangements to do the retrieval. We also, our skin bank and tissue bank is almost through, and we have anybody who would like to utilize these facilities also will be free for that. Next slide. So yeah, we have a bit of success, and people have recognized our efforts. Next slide. Slides. So we were felicitated 3 years in a row for in 2017 as the second best state, then 18 as the best state, 2019 as the best state, and 2020 also we have 20 and 21. We have been the best roto in India, roto and best soto. That is, our activities have surpassed the other activities of all over India. Next slide. These are just the photos of the program in Delhi. And thank you very much. And I'm willing to take up any questions you have. Do visit our website for updates and keep in touch. And we will be available for you at any point in time to give you 1:1 support. So do not hesitate to contact us if you require support. In case you have not understood anything about this program, you are more than welcome to call our office, and we will solve your questions in case they have not been addressed on this forum. Thank you. I'm through.
Yes, yes. Thank
So
you so
I'm
much,
willing
madam.
to take questions.
Yes, yes. Thank you so much, madam. Dr. Vijay Shivpujay wants to ask a question. Dr. Shivpujay, please unmute yourself and ask a question.
Yeah. Sujata ma'am, I'm Dr. Vijay Shivpujay from Solapur. Hello.
Yeah, yeah.
Madam,
Hello.
I want to ask you about once the organ is retrieved for the and shifted to the transplant center, and for some reason, if this organ got rejected or the transplant center refuses to accept this because of they find it not suitable, what to do with this organ?
Yeah, that is a very major question, because ideally you are not supposed to discard the organ. If you have to remove it, you have to transplant it. So when you are planning to do the retrieval, you should be very careful that the donor is in a fit condition and the organs which you are planning to remove are worth transplanting. Otherwise, don't remove it. Even during the time of retrieval, if you tell the relatives that the organs are not in a good state and we are abandoning the retrieval, it is good. But as you said, recently we ourselves had this problem that we accepted a kidney from Jaslok, and it came to our OT at 9 o'clock. And our patient was a known case of multiple access failure, and we opened her up, and we found that right up to the suprarenal IVC, everything was a fibrous cord. There was not a single vein in her body in her where we could have put the renal vein. And then we offered the organ to, it was a marginal donor, and we had also accepted it with very much risk because this patient had access failure, and unfortunately we could not use it because you can't go above the kidney to put a vein. Where will you put it?
Then
Where will you put the artery?
What
and
to
how
do
will
with
you
this
send the
organ?
ureter? So we had to send it for histopath.
Okay.
And we had to make a proper note of it. And ZPCC Mumbai and all the committees which are involved were because this organ got refused subsequently by all other hospitals. Though we offered it immediately to the next this thing. Our next patient online also, you know how the word of mouth goes that it is marginal donor, and he refused. So this happens sometimes. I think there have been totally 3 instances where this has happened since 2001. But yeah, it is a possibility.
Okay. Another question is you mentioned about recognized trauma surgeon. What is the process for that, madam?
Yeah.
I have been assisting and doing the transplant.
Surgeon.
Yeah, process or
So if
application.
I assume you have done your MS General surgery and assisted more than 25 transplants, you have to have your logbook officially signed by the place where you have worked, and this has to be given through a transplant center. You some transplant center would like to have you as a transplant surgeon. So through through them, you have to apply to DHS as a transplant surgeon with this logbook, and that's it.
Okay. And last one is, madam, you have arranged a cadaver retrieval workshop. That is good news for us. But what about doctors from the outside the Mumbai?
As I told you, this is our first venture. You know that the first time is going to be difficult. Quality of cadaver, Then will the staff work? Will we be able to do it? So we want to have the first program only within Mumbai. And from May onwards, we'll have a program every month and it is open to everybody.
Yeah.
It will be coming on our website, Rotosoto website, plus in all the groups which are related to us. We'll inform IMA also in case you get that information. But please do keep a watch on our website because we are planning to have one program every month.
Oh,
Only
thank
the
you.
first one we are, you know what, we are also learning. This is so I have done about 3 to 4 retrieval workshops, but I still have a little bit of apprehension as to how this will go. So yeah, from May onwards, you can definitely join us whenever you want.
Yes, so I
We
now,
are going, this will be sponsored by the Liver Society of India and Urological Society of India. But individual surgeons are also welcome. Registration is compulsory, but we are not charging very much, about 1,000 rupees per person. So that's it.
right. So regarding this was regarding training as a transplant surgeon, but as I've informed everybody, we are undertaking with the help of Rotosoto, we'll be taking up the next program that will be undertaking is how to register your hospital as an NTORC, and that is also a very important aspect. If at all you have all the facilities, what are the facilities needed, what are the requirements, and how you can register yourself. So this will be our next training program, which will be coming up with next month. And with this, I invite the last question of the day. We don't have the name of the doctor. It is mentioned as Rajni's iPhone. Sir, please unmute yourself and ask your question. Sir, at the bottom left corner, you have a mic button. There'll be a red slash across that. Just click on that. Bottom left, extreme left corner. Bottom. No. So you are not able to unmute yourself. Sir, see, I'm sending you a message. I'm asking you to unmute yourself. Just click yes. I'm sending you a message. The host would like you to unmute yourself. Yes. Can you unmute yourself? No. Okay, fine. So with this, thank you so much, Patwardhan Madam. You have been extremely elaborate and you have explained the working of Rotosoto and all the, in nutshell, you have explained the laws related to the transplant of organs in India. And with this, we come to the end of this session. And thank you so much, Madam, not only for taking the session, but of course, as the director of Rotosoto, for being associated with Indian Medical Association, Maharashtra State Organ Donation Committee, for organizing these various programs that we are doing to raise awareness regarding organ donation in the medical professionals. So thank you so much, Madam. And with this, present to you the certificate of appreciation from IMA Maharashtra State for taking this session on working of Rotosoto Noto with overview of transplant laws during this organ donation awareness program, Train the Saviors, organized by IMA Maharashtra State Organ Donation Committee in association with Rotosoto on today, 23rd March 2022. So thank you so much, Madam, once again. And with this, we...
And I'm sorry for not being able to join. It was relatively urgent legal meeting and I was not permitted.
No,
in
Madam.
Between also the phone call came for that problem. So do excuse me for not
at all, Madam. We
Thank
understand.
You very much,
Yes,
and I really appreciate your efforts in conducting all this. Thank you.
Yes, thank you so much, Madam. And with this, we come to the end of session. And as I said that we will be organizing, I have already informed about the MMC points that it takes about 2 to 3 weeks. The MMC point certificate is never issued. The MMC credit points of all those who have attended, the attendance will be taken from the chat box where you have put your name and your registration number. And also we have taken screenshots at various intervals. So with that, we will be taking up, your attendance. I hope everybody's put your attendance in the chat box. If somebody is still missing out, we still have 5 minutes. You may please put down your attendance in the chat box with your name and your MMC registration number. With this, we come to the end of the session, and I would sincerely like to thank Fortis Hospital Mulund for giving us educational grant for this particular CME. I would like to, of course, thank Roto Soto for conducting this particular program in association with Indian Medical Association, IMA Maharashtra State. The speakers for today, Dr. Rahul Pandit, Ms. Sujata Ashtekar, Dr. Prashant Borade, and Dr. Sujata Patwardhan, Madam. They have been extremely elaborate and they have explained their topics very, very nicely. And I hope the topics are made very clearer to everybody. In case you have any doubt, please feel free to write to us at organdonationcommittee.imams@gmail.com, or you can send a message to us on 9819018000. The recording of this program will be retrieved, and the recording will be shared with all the participants by tomorrow, because it's a big recording. It cannot be shared today itself. Will take some time. So we'll be sharing it with everybody by tomorrow, and this will be uploaded on YouTube, and the YouTube link will be shared with everybody. My sincere thanks to IMA Maharashtra State President Dr. Suhas Pingle sir and Secretary Dr. Mangesh Patte sir for sharing, for spending time, taking out time from the busy schedule and joining us for the start of this session. The team Organ Donation Committee of IMA Maharashtra State, and of course all the delegates who are here till the very end of the session to make themselves knowledgeable regarding this very important topic of organ donation. So let us be ambassadors of donating life and make changes and be useful in somebody else's life. So with this, thank you so much everybody for attending today's session. Until we meet next, we'll be meeting next for how to register your hospital as an NTORC. We'll be organizing this session and sending out the details very, very soon. So if you have a setup which you would like to register as NTORC, please do join us for the next session. Thank you so much. I'm going to be keeping this session open for next 2 or 3 minutes. If anybody has not yet put their attendance in the chat box, please do so. All those who have put their attendance in the chat box may please leave the CME. Anybody who's not yet done, I have just kept the CME open only for them to put their attendance in the chat box. Please put your attendance in the chat box only once. Do not put it again and again. Please put it only once. If you have put it, we'll retrieve it. Please put it only once. Anybody from out of Maharashtra who has attended this session will be issuing a certificate from Roto Soto Noto mentioning that this was granted 1 MMC credit point, and you can apply to your respective state medical council to get the credit points which are equivalent there. So thank you very much, everyone. I'm ending this session. Thank you for attending the program. Thank you so much.